Okay, so I think it's time to start. I would say that we are very happy to welcome you to this second day of EBC Virtual. And we start with this left main session of 1 hour 30 dedicated to left main disease and techniques and strategies. So I will co-chair this session with Tom Johnson, who will come a little bit later. Of course, Goran is in backup, and they can help me if I'm wrong. And let's start with Patrick Serruys, who will give us some lessons that we learned from the syntax study. Now we have more than 10 years of follow-up, so it will be very interesting to hear you, Patrick. And you are a friend since a long time of EBC, since the beginning.
On behalf of the investigator of the Syntaxes Freedom Pre-Combat and BEST trial, I would like to review some lessons from the syntax at 10 years and more specifically talk about the syntax score to 2020 and individualized decision making between PCI and CABG in complex coronary artery disease. I thank the board of the ABC for this kind invitation. The background of the Syntax Score 2020 is that randomized trials are the gold standard for testing the effectiveness of novel treatment. Average treatment effects are typically reported in randomized trials. However, treatment effectiveness can vary across individual patients. Average treatment effect may be suboptimal for decision making in individual patients. The syntax score 2, initially published in The Lancet in 2013, derived from 2 angiographic and 6 clinical variables, provide us an individualized decision making based on 4 years all-cause mortality after either CABG or PCI. And using the data of 10 years follow-up of syntax extended survival, published also in the Lancet, we thought to update the syntax 2 version 2020, published this week in the Lancet, for prediction of 10 years mortality and 5 years MACE, and to externally validate on data of the trial Freedom BEST Pre-Combat to validate the syntax score to 2030 for its ability to predict treatment benefit in mortality and MACE. You see here the average treatment effect as a summary result for 10 years all-cause death in the syntaxes. The all-cause death in the CABG was 24.5% and PCI 28.4%, an hazard ratio of 1.19, an increased risk of 19%, with a 95% confidence interval just between 0.99 and 1.43, a p-value of 0.066. Now, the question is, based on the average treatment effect, should you send all your patients to surgery? The response is, of course, not. Today, we are developing decision tool to improve personalized care in cardiovascular disease. We are moving the heart of medicine towards science. In panel A, you see the average treatment effect assessed in an heterogeneous population. And as you could see, looking at the average treatment effect, we have a mixtures of patients who will be armed in red, who will be armed by the new treatment, in green, the one who are going to benefit from the new treatment, and in blue, for which both treatments are équipoise. And looking at the average treatment effect, you have that kind of mixed bag, multicolor, small men, you cannot decide it. So it's very important to identify the heterogeneous response to treatment to segregate the patient population based on treatment response and identified in advance who is going to be harmed by the new treatment, who is going to benefit from the new treatment, and who for the patient for whom both treatment are equal. The syntax score 2020, just published in the Lancet, was redeveloped to predict the 10 years mortality and the 5 years MACE in the syntaxes trial, and we externally validate this result in Freedom Best Pre-Combat trial. You see there is 7 prognostic index and 2 modifier of this index, the anatomical syntax score and the disease type, 3-vessel disease of left main. Current smoking is new, came mainly from Freedom and syntax. Diabetes is back in the game. Gender has disappeared, and the other factors are still there: age, creatinine clearance, ejection fraction, COPD, and peripheral vascular disease. And what we have produced is a probabilistic formula so that if you want to send the patient to bypass surgery, use this formula with the blue term. If you want to send the patient to PCI, you have to use the red term, and you get the 10 years probability in the two options. And we have something similar for the 5 years MACE, prediction of 5 years MACE. What you see here is the cost validation of the 10 years mortality in the syntaxes, 1800 patients. You see here a calibration plot with the quartile of the whole population. On the vertical axis, the observed 10 years mortality after PCI versus the predict 10 years mortality. It's a remarkable regression line with a slope of 0.96 and an intercept of 0. And we have for cabbage a similar calibration plot, population divide in quartile, excellent slope, and intercept. Now, what we did is that using these two relationships, we look at the difference in 10 years mortality called treatment benefit of cabbage versus PCI. And again, you see a relatively good regression line. 1/4 of the patient will be better with PCI is better in 1/4 of the population. 1/4 is equipoise, and in the last 2/4, cabbage is better. Now, we would like to translate that in Kaplan-Meier curve, and in the first quartile with PCI better, we see that the survival of PCI in red is superior to the survival of the cabbage patient. In the second quartile, we have, and basically the absolute risk is in favor of the PCI. In the second quartile, equipoise, we see the two curves strictly superimposed, and the absolute risk difference is close to 0. In the last two quartile, we see that the survival of the patient is better with cabbage. The curve diverge and keep diverging, and you see that the absolute risk difference is 6.1% and 11. In this next slide, you see the external validation of the 5 years MACE model in the Freedom Best and Pre-Combat trial. 3,380 patients, same type of presentation, and you can see again the difference, this time in 5 years MACE, called treatment benefit between cabbage and PCI, with the absolutely risk difference in favor of bypass surgery or in favor of PCI. This is my last slide, which is available on the smartphone and on the website. This is case 1, 74 years old, an abnormal creatinine clearance with 38.6 ml, ejection fraction abnormal with 40%, current smoker, a left main disease, but a very simple left main disease with an anatomical syntax score of 11. And as you could see, the 10 years mortality is lower with PCI than with cabbage by about 10%. And similarly, the MACE at 5 years is better with PCI than with bypass surgery by 13%. In the second case, we have a rather young patient, 59, is diabetic but not insulino-dependent, good creatinine clearance, at least above 60 ml, good ejection fraction, a three-vessel disease, but according to the anatomical syntax score, very simple, a score of 10. And you see basically equipoise in mortality between bypass surgery and PCI, mortality at 10 years around 10-11%, and the MACE rate about 8.4, 9.3, equipoise, and probably the patient will be sent to PCI. In the third patient, 69, diabetes, insulino-dependent this time, creatinine clearance is maintained, ejection fraction is fine, a three-vessel disease, but a terribly higher anatomical syntax score. And you see that at 10 years, there is a gradient of 20% in all-cause mortality, the mortality of bypass surgery being clearly better by 20%, and the MACE rate at 5 years is also better with bypass surgery by 20%. So you have to, it's an ethical must to go to bypass surgery. In conclusion, using data from the randomized syntax trial, we have updated and externally validated syntax score to 2020, a personalized predictive model based on 7 prognostic factors and 2 pre-specified effect modifier. One is the disease type, three-vessel disease of left main, and the other is the classical anatomical syntax score. And then we can predict the 10 years all-cause death and the 5 years MACE for patient treated with either PCI or cabbage. Now, by providing expected probabilities of 5 and 10 years outcome, this model may improve the ability of the heart team to inform patients and their families regarding the risk and benefit of alternative treatment for complex CAD and support a more transparent shared decision-making process. Once again, thank you for the ABC board to have invited me to present this new data. Thank you very much.
Thank you very much, Patrick. I think it is very important to have this kind of information. Of course, we are missing one parameter which I think is very important, is the center effect, as you have shown at the 1-year follow-up with this outcome according to the centers. Now we are waiting for the comment of Greg Stone. We are very happy to have Greg Stone on board for the first time at the EBC, even virtual. So Greg, what are your comments about this?
Well, thank you so much, Thierry. It's really a pleasure. Let's see, the host has disabled screen sharing. I do have some slides. Can I share my screen to show you some slides?
Yeah, of course.
The host disabled participant screen sharing. So the host has to enable screen sharing.
Benjamin, can you?
There we go. They did it. Okay.
Thank you.
All right. Well, thank you very much. This is a, let me get this up here. You should be able to see my slides now.
Yeah, we can see.
Wonderful. So it's a pleasure to be able to comment on a trial that I've appreciated for so long. It's been so important to the entire field. These are my disclosures. I have no financial relationships with any stent manufacturers. So I do believe that when we look back on interventional cardiology, syntax will be one of those events that leave a legacy with lasting impressions. It was the first great trial of complex PCI with drug-eluting stents versus CABG. It was designed, however, with the hubris that with drug-eluting stents, there's nothing that the surgeon can do that the interventionalist cannot do as good or better. That impression did not last long after the one-year results were unblinded. The greatest legacy of the syntax trial, I believe, will be the anatomic syntax score and its implications. And we learned that although many patients fare well after PCI, anatomically, there is a bridge too far for PCI, even with drug-eluting stents. And I think this is still relevant with today's stents. The Syntax Score 2 and Syntax Score 2 2020 have further refined the prognostic discrimination for PCI and CABG outcomes, although it must be acknowledged the anatomic syntax score as a daily tool is starting to fall out of favor because of practical limitations. Sites just are not very accurate in determining the syntax score, and guidelines are considering no longer recommending it. In addition, there are several important limitations of syntax. Most importantly, it was performed with first-generation drug-eluting stents, which led to a high rate of stent thrombosis. There was suboptimal use of intravascular imaging, physiology, contemporary CTO techniques, et cetera. But CABG techniques have also improved. And background medical therapy in syntax is no longer considered optimal. So learning from the lessons, beginning with syntax and continuing through Excel, I think we have to adjust our thinking in three main ways, which are really relevant to Patrick's presentation. We must move away from this composite of MACE and MACCE, particularly MACCE, including revascularization, to emphasize the only two endpoints that really matter to patients, and that's quantity and quality of life. We also must stop focusing on relative risks and instead emphasize absolute rate differences. And with this, the number needed to treat to improve one patient is a very important metric. And we must prioritize patient preferences in clinical decision-making, not the doctor playing God. So this from Patrick's presentation, a very important slide showing a 4% mortality difference at the end of 10 years between first-generation Taxus stents and CABG. The difference was not statistically significant, but there was a trend. And Patrick appropriately said, does this mean you should send all your patients to surgery? Well, some would argue, does this mean you should send no one to surgery because there wasn't a statistically significant difference? But Patrick appropriately answers, of course, no, and you have to individualize your care. Well, I'm going to emphasize a different point, and that is, what if this difference is actually 4%? There's no doubt that if you were to randomize 200,000 patients, there is a difference in mortality between PCI and CABG. The question is, how big a difference is it? So if you take a therapy that reduces 10-year death from 28% to 24%, that's 0.4% of patients per year. That's a small absolute difference. The number needed to treat with CABG instead of PCI to save one life at 1 year would be 250 patients, or 25 to save one life at 10 years. So at the end of 10 years, 24 out of 25 patients are going to end up in the same place. So you have to communicate this to your patients, and there's a variety of ways to do it. Some people say we should be using charts like this. Show the patients, this is your survival. At the end of 10 years, either you're going to be one of these big green happy faces, whichever therapy you choose, or you're going to be one of these frowning faces, whichever therapy you choose. And those are the patients that will have a difference between PCI and CABG. So similarly, if you look at quality of life, the other important metric, here are the quality of life curves at 5 years in syntax. And yes, there may be statistically significant differences, but I don't care. These curves are essentially the same. They all have a minimally clinically important difference of less than 5. There's no important difference in quality of life between these two procedures. So in summary, we've got to stop pitting PCI against CABG. If it's a competition, the patient loses, as you see from this Zen birthday card, not thinking of you. Instead, in 2020, we've got to have entered the age of enlightenment where the patient must come first. We have to have a true heart team collaboration with mutual respect and the patient at the top of the pyramid. So always do what's right. This will gratify some people and astonish the rest. Thank you very much.
Thank you very much, Greg. It was really a great comment. So now we have to move to the next discussion. Tom, are you there?
I'm there. I'm embarrassingly sitting in a
Okay, so we cannot hear you. So the next discussion will be about the role of POT. Why
Certainly.
POT is so important in left main PCI by Jens Lassen.
Hello, everybody. I think that Ben should put the pre-recorded speak on.
Of course.
Yeah. But I can start on it if you like. So I would just say I'm very happy to be here, be part of the left main session. And it's a really important discussion and actually the way to move forward for most of our technical things. And I would be very happy to share the EBC views on why to use POT in the bifurcation. So Ben, if you would start.
Okay.
Good afternoon, everybody. My name is Jens Flensted Lassen. My topic is why proximal optimization technique is so important in the left main. But before we embark on that discussion, we need to dive a bit more into the biology and the laws of nature in the coronary arteries. The coronary arteries divide in a fractal manner, and what does that mean? Well, we can see from another part of the nature a riverbed from pictures taken from above. In the upper panel, we can see a river from 2 kilometers height in the left picture, and this is actually have a configuration that is very, very similar to the configuration of coronary epicardial arteries. If we go down to 500 meters altitude, and still it's Google Earth, it is real life somewhere on the planet, we can see the minor part of that river, which is actually comparable to the resistant vessel in the coronary arteries. And if we go even further low to 100 meters, as in the right panel, we'll see the small brooks that feeds the river, which is actually pretty close to the capillaries in the coronary arteries. And in the lower panel, the green picture, we can see a Malaysian river depicting the appearance of an epicardial coronary artery. And all these pictures show how a division is, if seen by a fractal manner. But it's not enough to understand the biology. Another thing was heavily discussed by C.D. Murray in 1926, and it was actually that the diameter of the branching in dividing coronary arteries correlates to the physical principle of minimal workloads. It also comes back to the angle of the branching arteries and the oxygen exchange in capillaries. And I really encourage you to look into this literature from Physiology 1926 to understand the biological background behind. But which are the implications of this? Well, from Murray's law and from some of our other colleagues, Girard Finet and our friends Hu and Kassab, the relation between the diameter in the distal part of a bifurcation and the proximal part is depicted in this picture. And this has implication because when we start stenting an area, we have to realize that a stent is tubular, but actually there is a huge discrepancy in the diameters from the proximal part of the main vessel to the distal part of the main vessel, which means that we need to manufacture the stent to the biology. Otherwise, we may hamper the biology. One thing that really is important is to realize that if we overdilate the distal part, we'll push the carina towards the side branch and then maybe close it. If we're going back to the topic, the left main, there are differences from the left main and all the other bifurcations in the coronary tree. One of the first differences is the oval shape of the ostium and the angulation, which means it's difficult to cover the ostium totally by a metallic stent. There are curved diversions and there are differences in the angle between the two side branches, but even more importantly is that the side branch is actually the circumflex, which need to be protected because it could have lethal complications for the patient if the side branch is loosed. And yet another thing is back to the fractal division and the dimension changes from the proximal part of the main vessel to the LAD. There is a huge step down of this tapering vessel from left main to LAD, which means that if we implant the stent with respect to the left main, then it would be heavily overdilated in the proximal part of LAD, and there will be a high risk of pressing the carina towards the side branch and close to the side branch in that respect. So now we are coming back to why do the proximal optimizations, and there are different reasons for doing that. But first of all, what are the steps and what can we do? So the first step is actually to implant the stent across the side branch with respect to the distal diameter. This is of course very important because that covers and protect the distal vessel and make a good stent deposition in that area. But we need to accept a floating stent in the proximal area, which need to be corrected for. This is done by taking a balloon with a larger diameter and place it with respect to the carina, as it can be seen here, and dilate it. Then we actually changed a tubular stent to be a tapered device, and we opened also the stent slots towards the side branch and preserve the side branch opening. If we put too deep with the balloon, we'll actually push the side branch carina towards the orificium. We will overstretch the distal part, and we will maybe lose to cover the proximal part, introducing another problematic thing, which we call the bottleneck. If we, on the other hand, put too high, we will not open side branches enough, stent slots enough to the side branches, which is another problem. So again, we need to manufacture a tubular stent to the biology, which needs to have a larger diameter in the top and a fitting diameter in the distal part, and at the same time opens towards the side branch. This is the proximal optimization technique. The proximal optimization technique can be done crossing over the side branch, but it can also be done reversely, as seen here, which means that we can start a left main procedure by provisional stenting and make the procedure built upon stepwise until we finalize. Maybe with 2 stents, but we may be able to stop with only 1 stent. So we can both protect the side branch up front and the main branch. It introduces different risk for the takeoff vessels, but this is not the topic for this talk. Why do we perform the POT? Well, it's reasonable to understand from what I've already said, but here we have from Visible Heart Lab in Minneapolis a direct angioscopy of a stent implanted with respect to what we were discussing, the distal diameter and the floating part in the proximal. And look what happens when we try to rewire. There, we just went behind the stent studs. And you can imagine what happens when we bring in balloons or other devices. We will actually deteriorate the proximal stent and maybe cross it. So it's extremely important not to lose the wire and be actually sure that you are not below stent slots if you lose the wire. So it's very important to do the POT after the first balloon dilatation to be sure that we actually change the geometry like this. Nicely wired within the stent and dilated, as you can see on the angio on the right and in the angioscopy on the left, making a very good stent deposition and avoiding the bottleneck. You may appreciate that there might be some floating struts in the proximal area. It will be corrected for in a bit. Next step would be kissing balloon dilatation, which has the purpose of open stent slots towards the carina and place the float divider in the middle. And again, from this angioscopic view, you can see the passing of the balloons, the passing of the wires in the distal cell strut, making a better coverage of the proximal roof of the side branch, and a nice result in the end. Okay, so after having implanted the stent and manufactured it the way we wanted, it's possible to move further on if we need more stents, either with a T-tap or a Q-lot, if needed. But there are other possibilities, as we can see in this quite busy slides. The DK cross technique is a two-stent technique up front, which actually don't leave the possibility to have only one stent. But also in these situations, it's important to have a proximal optimization in the left main, for the reasons that the stent is actually going from the ostium and the guiding catheter can cross the stent a bit. We need to take care of the carina area, open up to the side branches, and have taken care of everything. And then after the procedure is basically done, we finalize with a proximal optimization to correct for the oval shape and to correct for the crossed area. So having said that, we have the reason for why POT is so important in the left main. Thank you very much for your attention.
Thank you very much, Jens. I think we'll have comments from Yves Louvard. Before that, I would like to say that when we look at the different database, the rate of POT is very low. It's about 30, 35%, 40% maximum. So it's still very low despite your very convincing lecture. So what is the opinion of Yves?
It's nearly, I can say nearly the same as Jens, but I will have two comments. The first one is a description of a cascade of decision. What is important and is effective only if you have respected the distal main vessel diameter, because this is the way to give prepare two diameters in the same stent and to keep access to the side branch. After that has been shown, and we know by our fingers, that after POT is much easier to re-enter the side branch through the most distal side with a wire. And if you do that, you kiss, you have, as Jen said, the carina in the middle of the vessel. After that, you can insert a stent in the side branch without friction on the external part of the curve, because you have no new carina. You are just slipping on the ostium of the circumflex. So this is a cascade of consequence, technical consequence. And of course, when you do a POT, you don't exchange a wire outside, as said beautifully. Another aspect, short also, is it has been shown that the anatomy of the bifurcation is absolutely necessary for good function of the bifurcation, sharing flow, and the diameters are proportional to the supported myocardium volume. So it is very important also, and this is one of the functions of the POT, to respect the anatomy of the vessel, to end the procedure with three diameters, and not two in the main vessel. And I think this is a point of view, but I know that the echocardiographers have changed their mind. I think to do, for example, with a very tight lesion in the proximal LAD with remodeling, is completely crazy to use a media to media to stent the distal, to choose the stent. Because doing that, you will suppress the advantage of POT and having only two diameters. It had been shown in a study by Bonkonku on simulation, was a poor simulation, but was showing beautifully that even in a normal native bifurcation, you have region of low wall shear stress. The anatomy, the fractal anatomy, is the best compromise to reduce the surface of low wall shear stress. So having three diameters close to the native ones at the end of the procedure is prepare probably minimal neo-internal hyperplasia and restenosis. So these two aspects, technical aspects, and also an effect on the long term, that we know that some studies are not showing any effect at 1 year and showing at 10 years, that's the Nordic one, and can be some explanation in this restoration or not of the anatomy.
Okay, thank you very much, Yves. I think it's very clear we should respect the anatomy, especially in the left main, because there is a big difference in vessel size, and that's why POT is a part of the procedure. I think it's very important. So now Tom is back. Tom, can you introduce the next session?
Yeah, can you? I hope you can hear me now. So, the beauty of virtual is you watch it anywhere. I'm not sure a park bench is the place to try and start chairing a meeting. So we've discussed the importance of really a mandated pot. The next element is to consider debate between whether we should or shouldn't be using a final kiss for left main intervention. So we'll move to park, giving the first arm of the debate. Ben, if you can play the video.
Thank you for the invitation to present at the EBC 2020 meeting. The title of my presentation is really final case necessary for the main bifurcation PCI. Look at this, the treatment strategy for the main bifurcation as we can simplify one stent crossover, two stent technique. In case of a normal diminutive circumflex, we want to do one stent, diffuse this in large circumflex more than 2.5 millimeter. We want to do the two stent. When we have to consider one stent crossovers, when we have to consider two stent, according to the circumflex disease status by IBIS, we want to choose the one stent or two stent. First case is angiographically, truly bifurcation disease. However, IBIS findings clearly demonstrate normal circumflex. Ostial part free of disease. We're going to do just a single stent crossover. Second case is angiographically bifurcation disease. By IBIS findings, circumflex ostium has showed clearly severe disease. Large plaque burdens we did, two stent crushes is quite a good angiographic results we can get. If there are circumflex disease, true bifurcation disease, upfront two stent strategy are recommended for main true bifurcation disease. The reason why large circumflex disease is worth of treatment, we can avoid the risk of side branch closure. Clinical outcomes of two stent are good as much as one stent crossover. Right, I'd like to show the one stent crossover for normal circumflex. A 72 male patient treated bifurcation and main disease. By IBIS findings, circumflex ostial part actually very much, very minimal disease, almost a normal looking area. And so we did a main and LAD crossover, long stent 23, 3.5 millimeter size, additional high pressure with a non-compliant balloon. We can get clearly good angiographic results. The circumflex ostial part is clear, not compromised after stent crossover. Circumflex ostium, minimal stent area, minimal lumen area is 4.7 millimeter square. Look at this. There are many, different cases after single stent crossover from the main to LAD. Compromise of a circumflex ostium is a different morphology, 80% of a degree of stenosis and some radiolucence, some, calcific lesion, undetermined, functional class. However, all cases are negative FFR. The meaning is many cases of mismatches until the circumflex after the main stent crossover. So what do you think? In these cases, do we have to consider final kiss routinely? So we have some data after stent crossover, normal looking circumflex, functionally significant circumflex gelling is only 7%, very small percent of a compromised circumflex has a functionally significant disease status. 2 years long follow-up test and MI compared with the routine kissing balloon inflation and just the T4, actually no final kiss is safe and good. The circumflex T4 is good and safe. And so in case of one stent crossovers over for the normal circumflex artery for the main bifurcation PCI, final kiss is really necessary? No, it's not necessary in more than 98%. Right. Second case is two stent for the true bifurcations. Whatever you choose, any two stent technique, mini crush, DK crush, T stent, Gullop, V stent, Y stent, whatever you choose to stent, we don't have any data, different clinical outcomes according to the different two-stent technique, right? 70 male patient, true bifurcation, Medtronic class 111. By Ives findings, LAD ostium and circumflex ostium, there are pretty much plaque and disease status. So we did class mini crushings, two-stent on the circumflex and LAD, sequential high pressure, and finally kissing balloon inflation is moderate pressure. You can get very good angiographic result after kissing balloon inflation. So final Ives circumflex area 5.1 and LAD 8.8 millimeter scale is quite enough. Effective stent area 5, 6, 7, 8 millimeter scale by Ives can make a good clinical outcome. So restenosis less than 5% and tear rate less than 2%. So in case of a true bifurcation, is a final kiss really necessary? Yes, it's really necessary in almost all cases, but multiple stent for true bifurcation disease PCI status. So I'd like to summary practical guidelines, the main bifurcation PCI. Ives assessment is recommended both LAD and circumflex separately. If there is no disease or circumflex ostium, you want to do the single stent in almost 75% of a bifurcation and main disease. After stent crossover, do you want to treat the jailed side branch concern? Consider FFR first. How to treat kissing balloon inflation and optional T-stent, whatever you want. In true bifurcation, Medtronic class 111 or 101, so we're gonna do the two-stent, 25%. How to optimize? After the stent, effective stent area is 5, 6, 7, 8 millimeter scales may improve the long-term clinical outcome. Thank you for your attention.
Great, so a fantastic presentation. I hope now you are able to hear me. Apologies for the difficulties with connection. I think we'll move straight forwards to the counter argument and see what's felt in terms of the pro. Obviously, we've had a balance in terms of true left main disease, but let's move forward to the next recording if we can, Ben.
Chairman, thanks for the invitation to this very nice ABC meeting. I'm Dr. Descenzo from Turin, and the title of my presentation is final kissing balloon really necessary? We know that there are a lot of data, both from the bench point of view and both from the bedside, that is from the patients. You may see here this nice picture depicting all the possibilities of plaque distribution among carina. And we know that the bifurcation is really a complex tale. Even the struts were to perform the recrossing of the wire counts. You may see here that the proximal strut is probably the better, reducing the stent deformation in the main branch. And we perfectly know that if we perform reopening of the side branch without performing a final kissing balloon, this will increase strut distortions in the main branch and consequently increase the risk of stenosis and stent thrombosis. There are a lot of laws which taught us how to perform final kissing balloon, and you may see here just some of them. But from the point of view of the patient, that is where we are working on the cath lab, we perfectly know that we have to perform final kissing balloon when we treat patients with two-stent strategy. This is a propensity score analysis from one of our registry, one of the largest registry on bifurcation treated with ultra-thin stents. You may see on the left, after propensity score with matching, the results of final kissing balloon, yes, no, in patient treated with provisional strategy, and basically there are no differences. And on the right, the impact of final kissing balloon for patients treated with two-stent strategy. And you may see here that performing final kissing balloon reduce risk of TWR and OTLR, and especially reduce risk of stent thrombosis. And this, when we speak about ultra-thin stents, when we speak about optimizations of interventional strategy, probably is the most relevant things. When we shift from two-stent strategy, from provisional strategy, we have to assess some stuff. One of the most important is the relevance of side branches. This is a nice paper published on JACC interventions in which these authors tried to understand the importance of the mass, of the myocardial mass supplied by side branches. And you may see here that the most important relevant side branches are the first diagonal and the first obtuse marginal, and the predictors of a large amount of myocardium are the long side branch, longer than 73 millimeters, and of course left main bifurcation. So for example, when there are technical difficulties to protect a side branch, we have to remember these two variables are very long. This means a relevant distribution of myocardial and left main bifurcations. Shifting from this data to randomized control trial and to meta-analysis, this is one of the most relevant and one of the first trials to try to assess these issues. They performed a randomized patient with final kissing balloon versus no final kissing balloon. Only 7% of patients with unprotected left main and 50% of patients with true bifurcations. And very interesting, you may see here after 6 months, very low rates of events, but there were no differences in TLR and no differences in stent thrombosis. This is a meta-analysis which was published 2 years ago in PLOS ONE, and authors pulled together all the randomized control trial, and again, they saw no difference overall regarding MACE, regarding TUR, TLR, but they noted that final kissing balloon reduced significantly the risk of side branch restenosis, you may see here, but increase the risk of main branch restenosis. And this is probably related to the study I showed you before, that is when we do not perform proximal optimization or we perform a long kissing balloon, and it is a kissing balloon with a long overlap between the two balloons, this increases an elliptical deformations of the stance of the main branch, and this may increase the risk of stenosis because the elliptical deformations show the trend toward low shear stress, that is towards neoatherosclerosis or restenosis. And regarding this, we performed this paper, which I showed you before. This is the overall populations in which we divided patients, about 2,000 patients treated on bifurcation and also left main, about 1,500 patients treated on left main, to no final kissing balloon and final kissing balloon. On the overall population, the final kissing balloon did not give us any particular advantages in terms of TUR, on TLR, and of stent thrombosis. But when we divided this kind of final kissing balloon in final kissing balloon with short overlap, that is when the two balloons only show an overlap of 10 millimeters versus long overlap, the result changes. Very interesting. You may see here that rates of TUR decrease, no final kissing balloon about 6%, final kissing balloon with short overlap 3%, long overlap 7%, and the same result were shown about TUR, and the same trends, although not significantly, were shown for stent thrombosis. So the take-home message is that if we have to perform final kissing balloon, we have to perform with a short overlaps of the balloons, and this is very interesting, especially in timing of ultra-thin stents. And interesting, the results of this significance was confirmed also for patients when proximal optimizations was performed, showing the relevance of short overlap and showing that the proximal optimization probably cannot completely reassess the circular shape of the stent of the main branch. So we have to perform final kissing balloon with 2 stents. For provisional strategy, we have to perform as often as possible. When there are technical difficulties, we have to protect and to perform final kissing balloon on side branch very long with relevant distributions on the left main on the circ. And when we perform final kissing balloon, we have to perform with short overlap. Thanks a lot. It was really an honor for being here.
So a fantastic presentation from Fabrizio. It seems that we certainly have consensus in the sense that 2-stent or true left main bifurcation mandates the use of KISS. And obviously we're needing to reduce as short a length of kissing as possible. It would be really nice to involve Francesco Burzotta and Ronnie Mattew now, just to get their insights into what we've heard. Francesco and Ronnie, I don't know if you're there.
Hi everybody, you should activate my video, it's possible.
It's done.
Hi.
Yeah, hello Francesco.
Hi.
So
thank you for both presentations. I think that we are called into the discussion in order to try harmonize these two completely different signals. I think that in the first presentation, there was the signal all in favor of not doing kissing, and then you performed a presentation in which from other experiences, it seems that it might be a benefit with that. So I think that this is really not surprising, since kissing balloon inflation by itself doesn't warrant anything, because we learned by bench testing and visible art experience and imaging the fact that if we wire the side branch, the circumflex, in different cells, we have completely different results. So it is really something that we should take into account. When we are doing this kind of intervention, we should check what we do. We should attempt rewiring only after having performed appropriately POT, and we should refrain to perform interventions in the side branch, to perform kissing, unless we are 100% sure that we are in the correct position, we are not distorting too much the stent. So another argument in favor of performing kissing balloon inflation came from the very last EBC meeting in 2019. You see here in these slides this very new phenomenon, which has been reported during the cases presented at the last EBC meeting. If you leave the stent struts over there, you have the possibility that during time this happened and has been brightly documented at 36 months, it is possible to have such fenestrated circumflex ostium that can be also associated with positive FFR. So all of this should be taken into account.
Yeah.
So Ronnie, what is your position? In fact, this slide is coming from your experience. Last year, you have shown that there was, you had 5 cases of long-term pseudo-restenosis of the circ after left main crossover. So maybe you have more patients today?
Yeah, thank you very much. And it's a pleasure to be here with the EBC once again. And I think the slide that was shown is exactly what's been happening for the last 3-4 years when we see the follow-up of patients. Now, if I can just summarize it, if you do a 2-stent strategy, I think final kiss is a must. The question is, what happens in an LM crossover? Now, obviously, I think as the speakers have said that if you've got a circumflex angiographic problem, you got to kiss it. The question is, what do you do when you do not see angiographically a problem? And I think at that time, imaging is of great help. As I have shown in last year, and I think this year, I have 3 more cases in the same series. If you leave a strut across the circumflex ostium, even if the result is angiographically good, over a period of 3 to 4 years, you are going to get neo-intimal growth over the stent struts, and that would cause a circumflex problem in future. And the issue is there really is no data for this particular subset. The Nordic trial took all bifurcations, not the LM bifurcations in question. Even the LMCA data that we have from Japan is an old non-randomized trial. We really do not know the answer or what happens if you leave a strut across the circumflex. And I believe very firmly that imaging is the way to go. And if you got a strut, you're going to move it out of the circumflex ostium.
So Ronnie, that is the perfect way of introducing the next 3 talks. So thank you. So I think we move forwards to talk about imaging. We'll get the insight hopefully from Jose de la Torre, from the Noble data, and from the Excel data set. There's been some important sub-study analysis from Noble recently, and then also from Nicolas Amabile in terms of the Lemon study from France. So we'll move forwards, if we can, Ben, to Jose's presentation.
Dear Chairman, thank you for the invitation to present at the EBC meeting 2020. The title of my presentation is Lead Main PCI, is intracoronary imaging mandatory, data from Nobel and Excel. This is my disclosure of financial interest. As you know, lead main PCI is associated with an accrual of MACE in the follow-up. As you can see clearly in these slides from Excel and Nobel trials at 5 years follow-up. So we need to optimize the results of the PCI in the lead main through an adequate clinical indication, refine applied modification techniques, the use of the best evidence supported glycolutein stents, appropriate stenting approaches, the use of intravascular imaging, and the application of optimal medical therapy after PCI. IBUS guidance for lead main PCI is very helpful to plan the strategy, to prepare the plaque, to size the devices, balloons, stents, and to optimize the results by assessment of stent expansion, stent position, stent ages, and potential stent deformation. Meta-analysis of registries comparing IBUS guidance and IJO guidance in lead main PCI show consistently an IBUS advantage in terms of MACE, mortality, and cardiac mortality. The Excel trial, a large trial comparing PCI and CABG, included in the PCI arm a high proportion, 70% of patients undergoing the procedure with IBUS guidance. Among these, 504 patients have analysis in the core lab. These patients were accordingly classified based on the minimum stain area. We have here the tertiles, and the comparison of low and high tertiles for minimum stain area shows that there is a close to significant differences in 30-day outcomes. These differences became significant at 3 years. And at 3 years, the group with larger minimum stain area has lower incidence of death, MI, stroke, all-cause death, MI, and stent thrombosis. The Nobel trial, the other important trial comparing PCI and CABG, included 600 patients treated with PCI. Among the 72% underwent IBUS guidance during the procedure. And in 224, the analysis was done in a core lab. The 5 years MACE did not show significant differences between the IBUS guidance group and the angio guidance group, but there was a trend for lower rates of events in the IBUS guidance. TLR of 5 years was clearly significantly lower in the IBUS guidance group with 5.1% versus 11.6%. In the right-hand side of the slide, we see the same analysis like in Excel, the comparison between the lower and the upper tertiles for minimum stain area. And here the difference in MACE rates are 5 years is very close to significance, a strong trend for lower event rates in the larger MSA group. But for TLR, the difference is dramatic. 0% TLR in the group with the larger areas for the stents compared to 12.2% in the group with the smaller stain areas. Very recently, also the British cardiologists published this large registry, including over 11,000 cases with lead main PCI. And they also observed a difference in mortality in follow-up between those with imaging and those without intravascular imaging during the procedure. But it's important that they noted that as the operated volume increases, the IBUS-related prognostic advantage increases as well, suggesting that the most experienced operators get the best from the intravascular imaging, as is really suggested by Kiko Mahara in the editorial comment. The most experienced interventionalists were those most knowledgeable in how to use intravascular imaging. So to keep really an IBUS eye, you have to keep using IBUS regardless of your experience in lead main PCI. What about OCT? This is a retrospective analysis. We have here this comparison between 3 groups, 100 patients each. They are matched by propensity score. And as you can see, the group with OCT and IBUS guidance have a similar outcome and is better, significantly better compared to the group with only angiography. This retrospective analysis should be confirmed, but suggests that OCT could be helpful as well in lead main distal disease. The guidelines give support the use of IBUS for lead main PCI with a 2A recommendation, but what about the optimization targets? And our group has published recently this study in which we really tested the effect in prognosis of a predefined optimization criteria for IBUS guidance during main stenting. In the slides, there is a gradient in the outcomes, and geography is the worst group, then is the non-protocolized with IBUS, and the group with the best outcome is the one with a specific protocol for IBUS guidance with predefined optimization criteria. This presentation is out of the scope of the details of this criteria, but is clearly presented in the manuscript. The optimal trial will give a definite answer in this regard, with 800 patients to be randomized to IBUS guidance or ARDU guidance during main PCI. To conclude, IBUS imaging guidance for main PCI is very helpful to plan the strategy, to prepare the plaque, to size the stents and the pod to optimize results. IBUS guidance for main stenting provides a prognostic benefit with respect to use on geography alone, particularly if you have a specific protocol with optimization criteria well established. OCT could be helpful as well, but we have much less evidence. My advice, finally, is no matter the good operator you are, get advantage from intravascular imaging when doing main PCI.
So thanks, Jose. So there's a lot to discuss and lots of numbers. I think we move forward to keep to time with Nicola, and then hopefully discussion following that to look at both IVUS and OCT. So over to Nicola.
Dear Chairman, thank you for the invitation to present at the EBC meeting 2020. The title of my presentation is intracoronary imaging mandatory in left main PCI data from Lemon? As you know, IVUS guidance can improve the prognosis of the left main artery lesion PCI and is currently recommended by international guidelines. However, we also know that RCT is superior to IVUS in terms of spatial resolution, and that this tool might be useful in this situation for better lesion analysis and vessel sizing, a more precise PCI strategy planning, a better procedural guidance, and especially the wiring of the side branch, and a better analysis of the early results, leading to a decision of further optimization. The Lemon trial was a multi-center prospective trial, including stable and unstable non-ostial left main artery lesion requiring PCI. The PCI was guided by a standardized RCT protocol, including at least 3 runs. The first run was performed at baseline in order to assess the metrics, the plaque composition, and decide the PCI strategy. The second run was performed after the stent was implanted, the pot was performed, and the side branch was rewired. And the purpose of the second run was to assess the wire position. The third run was performed after the side branch was dilated, a report was performed, or final kissing balloon inflation was performed. And the third run aim was to assess and identify malposition, expansion, and dissection in order to decide or not a further optimization. The Lemon trial included 70 patients, and the primary endpoint was the feasibility of the standardized protocol defined by the procedural success. 3 criteria was included in the procedural success that was achieved in 86% of all patients. This is an example of a patient included in the Lemon. So this lady had a 110 left main to LAD lesion that was treated with a 3.0 per 38 millimeter Everoli musculating stent, completed by a 4.0 pot with an angio result that was acceptable. However, when we analyzed the proximal part of our stent with the RCT, we identified a major malposition there, probably related to an incomplete pot. So this patient further underwent a kissing balloon inflation and a report with the balloon in a more proximal position and a better angio result. And the final RCT analysis showed that the malposition was completely corrected without any sign of dissection. So one of the main findings of our Lemon study was that actually just after a pot, although even if it looks really good on angio, you observe a high incidence of malapposition, either on the proximal part of the stent or in the distal part of the stent. This percentage was higher in the proximal part of the stent, probably related to an incomplete pot, and decreased on the final run, on the final OCT run, because of the correction that was applied by the operators. And when you go for all the malapposition parameter that you can observe on OCT, you see that there was actually a significant decrease of the radial extension, the length of the malapposition, or the maximal distance between the struts and the vessel. As you know, 3D reconstruction is extremely useful in bifurcation stenting for the wire position assessment. We all know that the best wire position is in a cell connecting to the carina, as you can see on these 4 different examples of patients included in the study. OCT is also useful to identify the patient with an incorrect wire position, like in these 4 patients. And in this case, you can rewire the side branch to get a better result.
You still see them, or they...
In our 70 patients included in the final analysis, the wire position could be analyzed in 68 patients, and the wire position was adequate in 81% of these cases. What was the influence of the OCT analysis on the PCI flow? Well, the wire was repositioned after the run number 2 in 15% of the cases, and finally, PCI optimization was applied after run 3 in 26% of our patients. Finally, we also observed in the Lemon trial that the MACE incidence was very low in our cohort, and that the 1-year actual survival free from MACE was 98.6%, which was very, I think, very good and very promising. So in conclusion, ladies and gentlemen, this prospective multicentric pilot study is the first to report the feasibility, the efficiency, and the security of an OCT-guided left main PCI according to standardized protocol. The OCT guidance impacted the operator strategy in 1 patient out of 4, and thus could represent a valuable option of intracoronary imaging guidance and a good alternative to IVUS. But the impact of this strategy on the clinical outcome has to be evaluated in larger randomized trial. Thank you for your attention.
So some really interesting data from Nicolas. We seem to be getting somewhere, that POT's mandated, and now we use imaging maybe to gain even greater insight to getting a perfect result. So we turn to Dejan Milasinovic in terms of companionship. How should we go using all of these insights?
Much for this opportunity to participate at the EBC 2020. My job today will be to discuss whether intracoronary imaging should be considered mandatory for left main PCI and why Compagnonnage could be the best way to go. So how do we go from mandatory, which implies a solid evidence base, to the concept of companionship, which is more or less learning by doing? This concept originates from the Middle Ages, where craftsmen used to, as companions, learn from each other practical skills. So let us first consider the evidence base for intracoronary imaging in left main PCI. These 3 points that you can see on this slide do, I think, nicely sum up the contemporary dilemmas in this field. The first is, what are the imaging markers of an optimal procedure? Secondly, how do we assess the quality of the so far obtained evidence, and what is the emerging randomized evidence? And thirdly, how do we standardize our imaging guidance so that it can be applied in a predefined manner? So to the first point, very early on, and you see this publication from 2011, which I think is familiar to many, was the stent expansion identified as one of the key variables when trying to use IVUS in this case to improve outcomes in left main PCI. Of note, The cutoff points that you see here refer to this particular study, and they were generated in a population of roughly 400 patients who were treated with first generation DES. Now we go to a more contemporary evidence, which is the first all-comer randomized study, the ultimate trial, which proved that IVUS could be associated with favorable outcomes compared to angiography guidance alone in this population. There was roughly 10% left main PCI, so it cannot be extrapolated to all of the left main PCIs, of course. Nevertheless, the criteria that were used here were stent expansion, as previously shown, the key variable, but also the result at the stent edges was assessed. Interestingly, plaque burden at stent edges was, and the cutoff point of below 50%, was the hardest to get. It was the mostly missed criterion of success in terms of IVUS guidance. So this being said, it appears rational to think that there needs to be a set of different criteria that are looked at when using intracoronary imaging for guidance for left main PCI. And this recent study from Dr. De La Torre Hernandez, published in Neurointervention this year, showed that having a predefined set of criteria for IVUS-based guidance will improve ultimately the clinical outcomes as compared to angiography alone, but also as compared to just using IVUS without a clear-cut plan and strategy defined prior to the procedure. Now, in this particular study, different criteria were combined, including stent apposition, stent expansion, and the result of the stent edges, both dissection and the plaque burden. But it also included the look at the proximal stent edge and the proximal stent deformation, which is known to happen in at least 5% of left main PCI cases and is associated with unfavorable outcomes. So to sum up, the evidence base, as we could see, does not contain specifically any randomized study dedicated to left main PCI that was either positive or negative. So it cannot be said that left main PCI should mandatorily be conducted with IVUS or OCT guidelines. There is just no randomized evidence for that. But that being said, I think that we saw enough evidence to realize that imaging can be used as companion in our left main PCI cases because it has practical advantages in identifying areas of possible improvement that could be associated with better outcomes, mainly the stent expansion, and as we could see also the result of the stent edges. However, there are also other areas, and this is one example, where we used imaging as a companion for left main PCI, which have not been addressed so far in a standardized way in so far conducted studies. And this is, for example, the procedural planning. So basically, in this case, we looked at the plaque composition, and here you see on the right-hand side of the slide, the IVUS pullback, which corresponds to the angio that you see on the left-hand side of the slide. And you see slowly, when you advance from the LAD into the distal left main, the plaque that is existent turns to be very calcified. And here, at this point that you see in the area of the distal left main, there is even a concentric ring of calcium. We use this information to prepare the lesion adequately with a scoring balloon, and we ultimately succeeded in achieving expansion of our stents. So we use the imaging as a companion, independently of the hitherto acquired evidence base. So in conclusion, there is no evidence for mandatory use of intracoronary imaging for left main PCI. Nevertheless, can be used, and it is used as a companion for practical advantage and for gaining practical information that will inform our decision making.
Okay, thank you very much. I think it was very interesting to talk about the role of compagnonnage. I was thinking also about the compagnonnage between operators. And as you know, there is a very important data from Xubo, who published a series of Lefèvre looking at by multivariate analysis the role of experience. And by multivariate analysis, the main predictors of event were the number of cases done per year and also the ejection fraction, but not IVUS. So it's time to have the comments of Nives, Gonzalo. Unfortunately, Jean Fajadet will not be here, but we can have some time to discuss about the role of intracoronary imaging for Lefèvre. So Nives.
Hello, good afternoon, and first of all, thank you for the invitation to participate. I'm going to share some slides with you. So is intracoronary imaging mandatory in left main PCI? Well, we have evidence from multiple studies about the potential prognostic advantage of using IVUS in left main PCI. It's true that most of these studies are not randomized, but however, IVUS has already a recommendation in clinical guidelines, the revascularization guidelines, that say that IVUS should be considered to optimize treatment of unprotected left main stenosis. So from what I heard from the speakers, I think that one of the most interesting data we got coming from the British study is that independently of operator volume and experience, IVUS can improve outcomes. And we always hear about having an IVUS eye because you did it in the past and then you got the knowledge and now you can do it without IVUS. But I think that maybe having an IVUS eyes can be useful for sizing. But there are some aspects that are simply not visible by angio, such as, for example, having focal areas of underexpansion, something that can be especially frequent in two stents bifurcation. And this is very relevant because we know that expansion is the main factor linked to events. This was shown long time ago, but we have more and more evidence. And actually, Chen de la Torre presented the results from the IVUS studies from Excel and Noble that very clearly showed this relation between expansion and events that follow up. So really obtaining a good expansion is key. And as I say, sometimes focal underexpansion is just not visible by angio. Another important topic that all the speakers address is the need of clear optimization criteria. And I think sometimes people don't want to use IVUS because maybe they don't really know exactly what they need to achieve with IVUS or what they need to look for in the images. And providing this optimization criteria is key for the implementation of IVUS in left main PCI. We have seen this paper from Chen de la Torre also in this regard. What about OCT? Well, I think the data from Lemon suggests that OCT can be feasible and safe in distal and mid left main PCI. What would be the advantage over IVUS? Well, of course, OCT would be more sensitive to detect, for example, malapposition. We need to maybe question what is the implication or clinical implication of a malapposition that is only visible on OCT and not on IVUS, but this is maybe for another time. But what is true is that OCT can provide very important information on the wire position after rewiring, and we are learning more and more that this can be useful to optimize the results in the side branch, and this is especially relevant, of course, in the biggest side branch that we have, that is the circ in the left main. However, I think OCT has a long way still to work in left main. It will be limited, of course, in lesions that involve the ostium, because we will not be able to see them. Also in diffuse disease, in situations where you really cannot assess the vessel size properly if there is diffuse disease. And well, of course, this is a pilot study. What is the external applicability in the populations of left main we treat that are usually old people, diffuse calcification? This needs to be addressed. We have on the way already enrolling the optimal study that will randomize patients to angio versus IVUS guided left main PCI. for the people that still need a randomized trial to be sure that we need IVUS. But what I like is this concept of using IVUS or imaging in general as a companion. Use imaging to help you during the procedure. Having objective information, you can avoid uncertainty or guessing, and you can confirm an optimal result for your patient. Thank you.
Thank you very much, Nives. I think I see that Greg is still here with us, and as you know, in Excel there was about 70% of patients who had IVUS guidance. So what is your what did you learn from that, Greg?
Well, you know, as you saw before, and this manuscript is almost in press, that there was a very strong relationship between the minimal stent area and IVUS and left main related events. In addition, we saw detection of stent malapposition, which when major was related to events, and stent deformation, which is often unappreciated, especially with ostial and proximal left main disease, and that was strongly related to events. So I can't imagine doing left main intervention being so important without IVUS. And yes, while it will take a large randomized trial, perhaps like optimal, to make it class 1 in the guidelines, I think the data is so strong from the multiple registries that have been done linking IVUS stent expansion, edge disease, malapposition, and malformation of stents to outcomes that, you know, this is the most important artery in the body by, you know, the most important inch in the body. So I can't imagine why anyone would want to not spend another 15 minutes and do either IVUS or OCT. I'd be fine with OCT for the distal and mid shaft of the left main, but it just needs to be done. We just need to take the time.
Yeah, I mean, I think all of those elements, Greg, go into the fact that the left main's bigger than we think it is. And the numbers that come out of your Excel and the Noble data show, and really importantly, against an Asian population, we're talking about different size for both American, European populations.
And we've shown that the South Korean vessels are definitely smaller, and we go up to at least 10 millimeters squared and even larger, where the event rates keep going down and down. And so, yes, so people have to get rid of the 5, 6, 7, 8, you know, from the Asan experience is not relevant to Western Europe and the United States.
Yeah.
Okay, thank you. So then we have to move to the next discussion, which I think is a real debate. So when treating a 111 or 011 distal left main, decalculus is the best technique by Dr. Chen, and provisional or reverse provisional is the best technique by David Indickley. So Dr. Chen.
Thanks, Chairman, for the invitation to present the EBC 2020. The title of my presentation is Decalculus is the best technique for Medina 111 or 011 distal left main bifurcation lesions. Similar to all kinds of false coronary bifurcation lesion, provisional stenting technique is the primary approach, including for Medina 101 bifurcation lesion. RID is always treated as a main vessel. However, after stenting main vessel, redistribution of lesions may require ballooning side branch or 5 kissing balloon inflation or even 2-stent technique. On the other hand, for Medina 111 or Medina 011 bifurcation lesion, 2-stent technique is much more commonly used. During procedure, operative concerns and stenting selection are usually based on the prediction of side branch occlusion, stent thrombosis, tight vessel myocardial infarction, and revascularization. Dissection, sparse, plaque, or current shift are major factors correlated with the presence of side branch occlusion of the stenting main vessel. And side stent and the expansion of stent are two major reasons for the occurrence of stent thrombosis. However, the presence of target vessel myocardial infarction and revascularization are multifactorial. So the next question is that can we predict the occurrence of clinical outcomes? For the prediction of side branch occlusion, COPIS registry trial provided that side branch baseline diameter stenosis minimal 50%, long side branch lesion length, and SS patient are strongly correlated with the side branch occlusion of the standing main vessel. Previously published randomized trial favor prominent standing technique or many kinds of two-stand technique for entire cohort of bifurcation lesions. However, so far there is no risk stratification for the prediction of worse clinical results only for Medina 111 or 011, two kinds of coronary bifurcation lesions. Previously, we published the DK-Quachi-2 trial comparing provisional standing technique with the DK-Quachi for Medina 111 or Medina 011 coronary bifurcation lesions. At 1 year follow-up, there was no significant difference in terms of the 1 year MACE between two groups. However, there was a significant reduction of TLR in DK group. But this difference will disappear if side branch lesion length smaller than 5 mm or side branch diameter stenosis less than 70%. So the result rests the possibility that DK-Quachi may be beneficial for complex Medina 111 or Medina 011 lesions. So previously, we established definition criteria from patients with Medina 111 and Medina 011 coronary bifurcation lesions with side branch diameter minimal 2.5 mm. When we established the criteria from the validation group and tested in another study group, finally we got one major criteria plus any two minor criteria. So it could be defined as a complex coronary bifurcation lesions. So also, previously we published the DK-Quachi 3 and the DK-Quachi 5 study compared the DK-Quachi with Coulomb standing technique or provisional standing technique for distal left main bifurcation lesions stratified by Medina 111 or Medina 011. Subgroup analysis demonstrated that much more benefits of DK-Quachi were shown in complex lesions. However, this finding was needed to be confirmed in a randomized study. So this is the aim of our definition 2 trial. We only included complex coronary bifurcation lesion defined by definition criteria. So finally, the primary endpoint was the tight lesion failure at 1 year follow-up. Safety endpoint was stent thrombosis. Secondary endpoint included, of course, death, cardiovascular death, incident with stenosis, myocardial infarction, TLR, or TVR. At 1 year follow-up, the prevalence of tight lesion failure was 11.4% in the provisional group compared to 6.1% in the two-stand group, mainly because of the high rate of TLR and tight vessel myocardial infarction in provisional group compared to two-stand group. So in conclusion, for complex Medina 111 or 011 bifurcation lesions, either localized as distal left main or non-left main, systematic two-stand, particularly DK-Quachi, which was used in 77.8% in our definition 2 trial, has less rate of 1 year TIF rate, mainly driven by reductions in target vessel myocardial infarction and TLR. However, why there was a increased target vessel myocardial infarction after provisional standing technique, which could be explained by our recently published Serruys OCT study, which showed the presence of long side branch lesions and vulnerable plaques in the main vessel could predict the occurrence of target vessel myocardial infarction after provisional standing technique. Thanks for your attention.
So thank you, Dr. Chen. We'll move forwards to Dave Hilditch-Smith, who I'm sure is going to give a very contra opinion.
So I'm going to take the alternative viewpoint to my friend Xiaoliang Chen and talk about true distal left main lesions and the provisional, and the title was or reverse provisional T, tap or culotte, which strikes me that the title writer didn't quite follow the meaning of provisional, because all of these are in fact provisional techniques. And so the only word that is required there is actually provisional. So the provisional approach is the most flexible of all approaches to bifurcations. It treats them in a sequential and stepwise manner. It's a logical, planned, progressive and systematic approach. And key to it is that the layers of complexity are added as necessary and only as necessary. So you stop when you have a good result. This means you may end up with one stent, you may end up with two, but as Jens Lassen says, if you start with two, you can't end up with one. So in the case of a left main true bifurcation, you would stent the main vessel, proximal optimize, and then ask yourself, do we need now to do more? If you do, you would rewire the side branch, say the circumflex, and do a kissing inflation, and ask yourself again, do we need to do more? And if you do, you'd stent the side branch in whatever manner you are most comfortable with or is most appropriate, then kiss, then repot. And again, do we need to do more? So at each stage, this treatment algorithm, if you like, is logical, sensible, straightforward. It's rigorous, it's flexible, it's fully versatile. It can be applied to pretty much every anatomy that you can think of. And it offers you crucially the option to do only what you need to and not what you don't. So I have to ask why DK crush has been so popular. And there are two reasons. One is the data, and the second is the aesthetics. If you like, cardiologists do, I think, enjoy doing complicated things and can be beguiled by the immediate angiographic result. It's a relatively complex procedure, so at the end of a good DK crush, the cardiologist feels good about themselves, and they feel good because there's a lovely angiographic result, not taking into account the fact that where there are two stents when there might have been one, of course, there is the additional risk or opportunity for restenosis or stent thrombosis. There are some key drawbacks to the DK crush. It is inflexible because it does commit you to two stents from the start. It does require many steps for successful completion. It is quite a complex approach, and each procedural step that you add does offer you an original, novel, and potentially creative way to totally mess up your case. It does leave a triple layer of stent on the inner curvature of the main vessel, however short that triple layer is, and it does offer the opportunity to wire outside the stented area and leave an unexposed, uncovered area of vessel that's been injured. What of the data though? Now, these trials have been excellently conducted and huge numbers recruited in record time. I think though it is important to mention some potential differences between these studies and other studies that have been done before. So in the DK crush 5 study, the pot wasn't mandated prior to rewiring in the provisional strategy, and there was an opportunity to pass behind the stent. And in that study, nearly 50% of cases had crossover to two stents. So that always undermines the comparison between studies when that happens. If we look then at the definition study more recently completed, side branch predilatation was strongly discouraged, but still happened in nearly 50% of cases, and a side branch kiss in the provisional group was only seen in a quarter of cases, despite the fact that these were long and greater than 70% side branch lesions. So essentially the side branch, which in this case is a main vessel, was untreated in 3/4 of the cases. So perhaps it's not surprising that the results were to a certain extent biased in favor of the DK crush outcome. We saw some surprising results in terms of stent thrombosis. So provisional T 3.3%, which is very high, DK crush very low. It was unfortunate that the planned angiographic follow-up, which was due to occur beyond the 12-month primary endpoint, actually quite often occurred before. And you can see here in this graph the effect, the oculostenotic response perhaps, when restenosis that was not clinically apparent was seen at an early repeat angiogram. The side branch lesions were very long in these studies. DK crush 16 millimeters, definition 20 millimeters. And actually these are lesions we don't see very often in Europe or the US. So there's something different there. And of course, these might well be seen to require a stent in their own right. And that suggests that maybe the Chinese patients are a bit different. The disease pattern is a bit different with such long side branch disease lengths, but also that the Chinese approach or methodology for coronary intervention is also different, and perhaps they're particularly skilled and aligned to the concept of the DK crush and not so wedded to the concept of provisional. So of course, whatever you believe in more, you will tend to do better at. All of this, I think, hopefully will be looked at in a slightly different way in the EBC main study, which should report in the spring. And then we will have some interesting data to compare between the two geographies. Thank you very much.
Thank you very much, David, for this great lecture about provisional as compared to DK crush. So now we can discuss with Sunao Nakamura and Goran Stankovic. Maybe we can start with Sunao.
Shall we first? Sunao speaking.
Welcome, Sunao.
Oh, hi from the Asia. So first of all,
thank you.
Okay, first of all, I need to say this is quite important issue, still debatable issue. But no doubt, Chen reported and proved that DK crush has many advantages in a left main intervention, especially in a true bifurcation region. But I have two comments. At first, maybe a little bit a different story. But in a 011 or 11 region, we still have a space to modify the region in the left main, especially reducing plaque by the DCA. Resulting could reducing the number of the stent, for example, 2 to 2 stent or 2 1 stent. It means maybe we can change the complexity in the left main simpler by reducing the plaque by the DCA. Second, absolute scientific truth, I think, is complex stent in the left main bifurcation region is if we can reduce the number of the multiple stents around the circumference occiput area, may lead to reducing a restenosis rate. From this meaning, I think a DK crush is one of the best techniques to reducing the number of the multiple stents around the circumference area. Maybe should be okay. But my rationale in a complex stenting is at first, want to modify the region as possible as we can. Second, want to finish one stent as possible as we can. And third, if you cannot avoid a two-stent strategy, I recommend choose most favorite one or familiar one for you, because this is very technical demanding. This is my comment.
So Goran.
Thank you, Tom and Thierry. So I will say that we need to distinguish two different aspects. One is anatomical complexity, but we don't forget experience of the operator, because as David said, and I fully agree, we have extremely complex patient population in both studies, DK crush 5 and definition 2, and disease which is in the circumflex longer than 20 millimeters. We know from the Benesten study that balloon cannot be compared with stent. So having stented that artery, I think it's a natural course of planning. The main issue is whether we are starting by stenting main vessel first or the side branch first. And I don't have doubt that in such diffuse disease, inadequately sized circumflex, we can modify strategy and stent circumflex first, and it's still provisional. As we discussed yesterday, having second stent in provisional is not bailout. It's planned two-stent strategy, just started by stenting circumflex from the left main. And the second is, of course, anatomical complexity. And as I said, we need to clearly put in one side such diffuse disease of the circ that was present in these two studies compared to probably 90% of other bifurcations of the left main without such a diffuse disease of the circumflex. And in my view, provisional stenting main or side branch first is the gold standard, even with the results of DK crash studies.
Great, thank you. I mean, clearly there is this discordance in philosophy between going for a two-stent strategy, which seems to be favored in China, versus the provisional approach, which is clearly endorsed by Europe. But I think we all agree from Sanaz's comments that the importance is the kissing the pot that's going to ensure that we don't leave malapose struts regardless of which strategy is deployed. So just to really upset the apple cart, we now move on to Francesco Burzotta to talk about trifurcation left main. So why not make it even more complicated? But Francesco, maybe you'll offer insights into really the most truly challenging left main anatomy.
Francesco Burzotta from Rome. I'm glad to be here at the European Bifurcation Club 2020 to present approach to left main trifurcation, make it simple, not simpler. Left main trifurcation might be defined in a different way. What makes sense is to couple the fact that there are three branches in the left main with the fact that those branches have an appropriate size. So, and usually more than 2.25 is what is accepted as a relevant side branch. It is also important to note that intermedius might take off also from LAD or for circumflex. Usually the cutoff is 3 millimeters to have a trifurcation. The anatomy of a trifurcation can be described according to several laws that regulate the branch size and the flow across the side branches. Among those, the Finet's law is very practical because it is what it is usually also applied to bifurcation. What changes is the coefficient for the correction. Regarding the classification of the disease and the pattern, we know that in the clinical experience we may have all kinds of distributions. However, the complexity of a left main trifurcation increases when we have the plaque which involves the area which is set around 5 millimeters from the bifurcation, proximal and distal. So this is the true bifurcation trifurcation lesion we are talking about. And regarding the classification of this pattern of disease, there are several classifications. Probably the most adopted one is the modified Medina classification, in which we set O or 0 or 1 to the presence of disease into the left main, LAD, intermedius, and circumflex. And the most complex situation is true bifurcations, which is in red in this slide. Does the complexity of the left main trifurcation disease impact when we decide to perform PCI? The answer is clear, is yes. We have two independent studies showing that after PCI, the clinical outcome of patients who had true trifurcation are clearly worse as compared to those who have non-true trifurcations. Looking for the perfect technique is what we are doing into probably the last 20 years. So honestly, we are daily treating patients with tubular stents, and when we have bifurcations or trifurcation, the problem arises. If we have lesions like that, in which definitely there is involvement of all the branches, we may, during the practice, be able to achieve this fantastic result. However, it should be acknowledged the fact that in the first case, 3 stents have been implanted, while in the second, just one stent and several manipulations have been done. So there is no unique way to achieve this result. The good result is probably one of the main, the first aim of our procedures. However, when we look at the clinical outcome of patients who received PCI, according to the stent number, some signals does appear. In particular, if we compare 1 versus 2 stent techniques, this is a study by Dr. Chen showing that there is significant adverse measure adverse events increase in those patients with 2 stent techniques. And sometimes we need to implant more than 2 stents. When we perform breakdown according to the number of implanted stents, you see that there are 2 independent studies showing that as soon as we increase the number of stents implanted into the trifurcation, we have on parallel also a more common adverse events during the follow-up. So it is clear that not only the technique makes sense, there is the baseline impact of the complexity we are treating, but as a general rule, to try to implant 1 stent might be something which may warrant a better outcome into the long term, at least in the absence of randomized trial. And how to adapt provisional to left main trifurcation? It is probably a difficult job because we already mentioned that we have tubular stents to manipulate. To better understand this, we performed into my university several bench tests in a silicon model of trifurcation which resemble the most common anatomy according to the atlas of human coronary left main available. So this was done, and I think we did was to perform the probably most simple technique, which is sequential kissing technique. According to this, after having implanted the first stent from the main vessel toward the LAD, we rewire both the branches, and then we advance the 2 balloons to have the sequential kissing into the intermedius LAD. And then, since the circumflex has not been open, we leave the balloon into the LAD and we perform the kissing between LAD and circumflex. I mean, this is just one way to manage a trifurcation with double kissing, but the result which we have been able to document is really promising. There is a good shape for this the stent after these manipulations, and this technique is compatible with 6 French guiding catheters. A dedicated technique for trifurcation in the setting of provisional is tracing inflation. According to this technique, we implant the first stent in the same way, left main toward LAD, then we perform the double rewiring to have access to intermedius and circumflex, and then at this stage 3 balloons are advanced inside the 3 branches, having the overlap inside the main vessel. It makes sense to do it sequentially so that we may check expansion, and then there is the tracing balloon inflation, which is something which is not common, but has the benefit of allowing to fix all the bifurcation area, all the 2 carinas and all the angles with a single manipulation, which is the tracing inflation. This technique is technically challenging and should be known that can be performed just with guiding catheter which are larger than 6 French, so need really to be planned on advance. Which results for this technically challenged technique? Well, we again have no huge data to support this. However, there is one publication by Kubo and colleagues who reported into the single stent group in which tracing balloon was the modality of management for side branch, very low adverse events during the follow-up. In this particular case, it was target lesion revascularization rate, very promising results. Is there any way to let this challenging technique be a little bit more friendly? Well, in my lab with my colleagues and particular Carlo Trani, we set up a technique allowing to inflate the 3 balloons needed for tracing with a single indeflator device. This is something that can be considered in the practice, especially in the case we do not have many expert operators with us while treating trifurcation. Thank you for your attention.
Hello and welcome to EBC 2020 Medtronic Sponsored Symposium Advancing Left Main PCI. My name is Goran Stankovic. I'm international cardiologist from Belgrade, Serbia, and it's a pleasure to work and discuss left main PCI with my colleagues and friends, Dr. Milva Talsnag and Dr. Tom Johnson. This is the agenda of our session. So I will initially discuss anatomical challenges of left main and quickly go through EBC consensus on left main PCI. After that, Tom Johnson will speak about state-of-the-art evidence for left main PCI. Then Mirva Talasnag will present complex left main case, and we will discuss the strategy, and we will discuss how to improve EBC consensus based on the most contemporary strategies and techniques used. I will end up by wrapping up and sharing learning resources. Left main is different bifurcation because it has certain anatomical characteristics. Compared to other bifurcation, the main difference is large proximal main vessel with large discrepancy in caliber between proximal and distal part of the main vessel. Then compared to all other bifurcations, B angle between LAD and circ on the average is 80 degrees, so it's T-shaped angulation. Left main is also the area prone to calcium deposition, so it's very frequently calcified. Ostium could be involved, and side branch is never small because side branch is circumflex. In 10% of cases, there is also trifurcation, which may have influenced our decision making and the strategy. So these specific anatomical characteristics have significant impact on the stenting technique because POT becomes mandatory and the essential step, and we also need to consider stent design with large diameters necessary to cover left mains, which goes up to 6 millimeters. Then because of T-shaped angulation, we need to be careful when selecting the strategy. Aorto-ostial involvement is characterized by higher elastic recoil and the risk of longitudinal foreshortening, and also in calcified lesions, lesion preparation is the key for successful stent deployment. EBC has published recently EBC consensus document on left main PCI, and one of the main messages is that in left main disease involving both branches, stenting technique should depend on individual patients' anatomical characteristics, but we need to take into consideration also the operator skill. However, our general strategy for left main, as well as for all other bifurcations, is provisional. But provisional, although standard strategy, is actually treatment philosophy, and it's not just technique of single stent. We start by stenting main vessel, respecting distal main vessel diameter. We do POT to respect the original tapering, and then in case side branch is compromised, we continue with dilatation. If still compromised, we do side branch stenting using T-tap or culotte. And this is our algorithm based on the risk assessment for losing the side branch after main vessel stenting. So if we don't expect the high risk of losing the side branch, our standard strategy is provisional. And then if second stent in the circ is necessary, we do T-tap or culotte. If we have major concern regarding losing the side branch, then we can either start by double kissing crush or by inverted provisional, and then again finalized by inverted T, tap, or inverted culotte. So I'd like to conclude that for left main PCI, provisional side branch stenting is recommended for majority of lesions. Stent technique should depend on individual patient's characteristics and operator skill. Elective two-stent strategies may be considered for important side branch with complex and extensive stenosis, difficult side branch access, or high risk of side branch compromise. Among two-stent techniques, there is strong randomized evidence for double kissing crush, while EBC main results are awaited. Thank you very much for your attention. The second lecture will be presented by Tom. Tom, please.
Goran, thank you, and thanks for the invitation to join you to discuss the state of the evidence in advancing left main PCI. 5 minutes for this is a somewhat tall order, but I'll do my very best. So I think since we met last in Barcelona, there has been some fairly major fallout, and the EACTS meeting of 2019, apparently inspired by Genius, led to the most incredible fight really between intervention and surgery, to the extent that in the UK there was some fairly damning news reporting, particularly BBC, where heart doctors were said to have held back stent death data, and as a consequence it was highlighted that the surgeons had withdrawn their support from heart disease advice. And we saw around Christmas time this withdrawal of the EACTS support for the 2018 myocardial revascularization guideline. And so this was a fairly troubling time, and particularly with this accusation of the fact that intervention carried greater mortality. Now, since then, there has been some further work done, and this is a meta-analysis published by the Imperial CRF group in the European Heart Journal, which reassuringly highlighted equipoise really in terms of mortality associated with percutaneous and surgical revascularization. However, I think we have to acknowledge as an interventional community that there is a hazard in terms of unplanned revascularization in favor of bypass surgery, and we really need to improve our consideration of patient selection and enhancement of techniques, as Goran has already alluded to, the techniques that exist for left main stem PCI. So where are we in terms of evidence? Well, we've published actually from the UK data set an all-comer outcome report from the British Cardiovascular Interventional Society, a 4% absolute reduction in mortality to 1 year with the use of intravascular imaging for unprotected left main stem. There have been reports previously, but this is fairly compelling in terms of supporting an image-guided approach to the use of intervention in left main stem. Now that very much fits with the South Asian experience, and we see in Korea a 75% penetration of IVUS guidance use, and this is a nice report comparing provisional versus two-stent technique in the left main taken from 2 large registries in South Korea. And again, importantly, highlighting this relatively low mortality, similar between single and dual stent. We see no difference, although numerical difference, in terms of target lesion failure in favor of provisional approach. There is this striking signal of target vessel myocardial infarction, I think highlighting the complexity of intervention, both with provisional and two-stent approaches. And then we see out to 36 months hazard in terms of target lesion revascularization. Again, not significant between the approach of a single or two-stent approach, until they broke it down to looking at simply the second generation DES population, or just over 700 patients, where we see a favor for the provisional, the simpler approach as supported by EBC for treatment of left main. Now, contrary to that, then we've had, again, contemporary data published from a Chinese group, Definition 2, comparing again provisional versus two-stent strategies for complex bifurcation, of which about 30% were left main stem and truly complex, 85% Medina 111. And we see there then two-stent technique favored over provisional, with this quite striking target vessel myocardial infarction rate very early associated with the acute intervention. And this is somewhat puzzling in the setting of two-stent approaches, which are procedurally more complex, take more time, and interestingly also in a population where imaging was only adopted in a quarter to a third of patients. Now, if we turn back to the Korean experience in terms of IVUS, we know that there is a kind of mandate to try and achieve this 8-7-6-5 MSA sizing of left main, polygon, LAD and circumflex. And there's been some very nice data published now from the Noble study looking at an IVUS subpopulation, and in fact highlighting this discrepancy between the Asian population and maybe a European population, where the MSA value in left main was actually around 12, 16 in the polygon, 10 in the LAD, and just under 10 in the ostium of the circumflex, so far exceeding, in fact, the rates that were suggested as the kind of standard to be met by this Korean study. And there are only a small number, 3 to 5, 7% of patients that failed to meet the 8-7-6-5 criteria. Now, the Noble group have interestingly then broken this MSA into terciles, and we see that with the highest tercile, the largest MSA, no events in terms of left main target lesion revascularization out to 5 years, against where we have a smaller MSA here of 10 in the left main against the 8 that was given as a standard in Korea, we see a much greater hazard. So I think we're evolving our technique, evolving our strategy with the use of intravascular ultrasound in left main. And really the point I'd want to put across is that we often talk about optimization by imaging, and we should shift that to guidance. And we see here a difference between patients who had no IVUS use against those who had IVUS pre and post deployment of a stent, and then have used before or after, but not in both, a fairly matched result. But really highlighting this importance of using imaging from the beginning to the end for lesion characterization, for vessel sizing, for stent optimization. So I think we've had an interesting year in terms of state of evidence. I would suggest that comparison of surgery against intervention is unfair. It's comparing apples against oranges. I think what's come out of this argument, though, is that patient selection is essential, and there's a crucial role for the heart team. So patients should be discussed and patients should be given a choice. But mortality, importantly, there's equipoise between the two strategies. We have to acknowledge PCI is complicated by target vessel failure, myocardial infarction. Provisional versus two-stent role, I think we've seen data that can support either, and we await EBC main. And then following that, I think absolutely there is a role for image guidance to enhance outcomes. I thank you for your attention.
I'm going to present a case where we did left main bifurcation stenting using decay crush technique to treat osteostenosis of the left circumflex coronary artery, and hopefully highlight some of the points that were mentioned by Dr. Johnson in his presentation a few minutes ago. This is a left main bifurcation where we elected to do a decay crush on circumflex. This is a gentleman who was 65 years old, presented diabetic, had preserved left ventricular function and normal kidney function. He presented to us with angina, chronic stable angina, and an angiogram showed a chronic total occlusion of his LAD, and this was in 2012. So at that point in time, we opted to have dual access and kind of do the usual PCI. This patient required re-entry with a stingray, and then we ended up stenting the patient. We tried to nail the oxygen all the way back to the left anterior descending artery, maintaining the circumflex as is. And this was the final shot in 2012. He did well for about 2 years when he came back to us again with chest pain, and we did a relook, and this is what we found. We had the LAD, and the LAD stent was widely patent, but now we see a disease or focal stenosis of the ostium of the circumflex. So I think here, and perhaps open it to discussion.
Yeah, thank you very much, Mirvat. I think excellent first recanalization. Looks like stent in the LAD was perfectly open. I think procedural results look great. I don't know if you did imaging at the end of the initial procedure, but now I'm sure we need some more data in order to make appropriate understanding of what was the reason for failure. And it's a pleasure to have Tom Johnson as the first author of the recent consensus document from EAPCI. Tom, what can you share with us about this case?
I think firstly, I urge Mervat not to cut herself up too much about the fact that you tried to nail the ostium. I think it looked reasonable as an approach in 2012, that there was sufficient landing zone. I guess that in terms of re-entry, dissection re-entry, I mean, you entered the subinterval plane, I guess, in the proximal LAD segment. Looking at this lesion now, the worry is that there's been plaque shift or there's been progression of disease due to traumatization at the ostium of the LAD extending into the circumflex. And clearly now that we have a stent at the ostium, it makes intervention slightly more challenging in terms of strategy. But I think, as Goran says, we need more information probably. For me, the most compelling data was presented in the EBC consensus document for IVUS use in left main stem, which showed that by using imaging, we highlight much greater complexity than the angiogram allows. So I'd be very interested to know what the ostium of this LAD looks like and the disease burden at the distal left main, because clearly that's going to influence your strategy in terms of how you treat this by a second stent.
Thanks, Tom. Let's see what Mervat has actually done at that time, and let's learn from this particular case of a failure at the ostium of the circ, which is really very frequent in our practice. Mervat.
Yeah, so at this point, we addressed surgery with the patient and the surgeons, as a matter of fact. So the patient was always reluctant to undergo surgery. It was a very emotional issue for him. He had a family member that didn't do well, and so he really didn't want it. But when we had a more objective discussion with the surgeons, their concern was you have an LAD that's widely patent, an LV function that has not changed in the last 2 years, and a patient who's coming with chronic stable angina, and they were, reluctant to take him to surgery for only a circumflex. So we discussed complex PCI of the left main with the patient and the surgeons, and that's where we decided to go on. Unfortunately, I don't have the IVUS imaging for this patient, but we opted to, since this was ostial circumflex disease, we wanted to make sure we cover it, and there's no geographic miss of the ostium of the circumflex, and felt this, and it's a sizable circumflex, felt the more suitable strategy here would be a DK crush. So what we ended up doing is dilating the ostium, wiring both vessels. So we have to wire in the LAD and the circumflex. We pre-dilated the circumflex. We positioned the stent and determined the length that we wanted. It had a balloon in the LAD, ready to crush afterwards. And afterward, deploy the stent in the circumflex, making sure we actually covered the ostium safely. And as I mentioned, there was a stent that was already across, there was a balloon already across that, ready to crush. So once that was deployed, we did our post-dilatation and then removed the hardware from the circumflex and went ahead and crushed the circumflex stent. So this was the first crush for this patient. We rewired both of them. We did kissing inflations over here, and we went ahead and started positioning a stent that went across the circumflex. So you can see that the wires and the that was in the circumflex had been removed at this point, and we're trying to determine the position of the stent that was going from left main into the LAD. At this point, we ended up deploying, and so you can see the second crush. It's probably easier in the LAO caudal view. You can see the crushed stent in the circumflex. And then we went ahead and did our proximal optimization, and where we did dilatation of this stent that was in the left main. Before we even wire the circumflex, it just feels easier. We don't end up wiring underneath any struts in an under-expanded stent in the left main. So that's what we were doing here. This is the plot itself, the dilatation. once we had a wire across, we did our second kissing inflation at this point in time. We did a pot one more time over here, and it's very important to determine, to make sure that the ostial struts are dilated appropriately, and we make sure we also know where our carina is right now that we had. And this was the final result for LAD circumflex DK crush this time around. So I think we have a lot of information now where, as Tom was telling us just a few moments ago, about the utility of intracoronary imaging. And this is perhaps a good time for us to discuss at what points we want to stop, do some imaging to help us guide and not just optimize these kind of complex procedures.
Yeah, thanks, Mirvat. I think it's really excellent final result. And also by OCT that was done at the end, you confirmed the position. I would start first by asking how you select devices, mainly the stent. It's a large left main. What was your selection? And a second question is, I'll let Tom discuss imaging, but my question is related to, you did 2 times kissing, and recrossing in kissing in DK crush is specific. We learned from Chen that we should aim for crossing proximal strat for the first kiss and maybe mid-central strat for the second. Is that also your practice? You are one of the experts for DK crush. So for the benefit of our audience, please share stent selection and recrossing.
Yes, so for the stent selection, it's important to decide that ahead of time. So it's important to make sure not only the diameter, but the appropriate lengths of the stents that you have and the balloons that you're going to use for both the kiss and the proximal or pot. You have the appropriate lengths that are not going to encroach on the carina. And a lot of the new generation stents, the majority of them, will expand appropriately. So what we actually ended up doing is you saw this was a very sizable vessel. We ended up with a 4.0 stent that we post-dilated to 5.0.
Excellent, yeah.
In the left main itself. And for the kiss inflations, we use both balloons, but moderate inflations in both vessels.
Yeah. And the second question is, when you recross into the side branch, in DK crush, you try to cross proximal. Is this also your practice?
Yeah, we're learning to do that as well. But, it's always easier to kind of cross with the loop, try to go into the main vessel, and then kind of pull back and cross in the appropriate segment. I think when we try to do it by eyeballing, it may be a little bit difficult. I think sometimes we're able to use stent boost and a clear stent, depending on the
yes.
you have. But I'll probably stop here and turn over to Tom to talk to us about the different phases of intracoronary imaging, where he would recommend that we go ahead and use either IVUS or OCT to help us through the steps.
Sure. Well, I mean, I think it's a really nice case, Mirvat. And the bit that strikes me most is this discrepancy between the left main size and the LAD, which Goran has highlighted in the very first introductory slides. And so clearly the decision-making in terms of an appropriate stent matrix that is going to be able to expand sufficiently for the left main, but be appropriately sized for the LAD. And so the first part of the imaging is to use it to make those decisions. So to understand the nature of the disease, but most importantly then to appropriately size. We're still learning in terms of using the imaging for the purpose of wire positioning, and that's part of the October study, which hopefully we'll have reported sometime soon in the future. I mean, looking down this OCT image reminds me of the Visible Heart Lab, which I think you may well have some images to share, but we have so many opportunities to get this wrong that we have to take care with every step. And so what imaging, and certainly the resolution of the OCT images you're showing here provide, is a very, very careful approach to ensuring that we make safe decisions each and every step. So here we see this beautiful illustration of the clustering of struts around the side branch. I'm honestly not sure, Goran, about proximal or mid-cross or which is the right place to go, because I don't think we can ever truly predict how the crushed stent in the side branch behaves. There's every chance you pull it off both the proximal and the distal edge of the side branch ostium. And so I think there's hazard, and we have to acknowledge that hazard every time we do these cases, with or without imaging, and just take the greatest care we can. And so the stent device actually plays a very, very important part in this, in terms of the way that it conforms. And this is a very nice example of how here the onyx is in theory, going to expand very significantly in the left main and potentially open up a much more sizable opening to the side branch for rewiring and ballooning for the secondary kiss.
Thanks, Tom. So Mirvat, any final remarks?
Well, I mean, this is actually what you were talking about from the Heart Lab. This is an image that actually shows when we do the appropriate dilatation, proximal optimization, we have more control over the wire recrossing. Again, it's a lot more theoretical where it eventually crosses, but we should try every effort at least to make sure that we're well expanded, the struts are open, and so we can safely deliver equipment without jamming anything. Just to give you a final update on this patient, naturally we had our threshold to relook is always low. So he came again in 2018 with chest pain. Fortunately, again, his LV function was normal and troponins were normal, but we did relook and his stents were widely patent and he's doing very, very well. So I'll kind of leave you with that here.
Great, thank you very much, Mirvat. I think this was a great demonstration of the most contemporary approach to distal left main treatment with double kissing crush as one of the standard strategies for diffuse circumflex disease, and also optimization of the result using OCT and imaging assessment of stent position inside the left main. Because of a huge discrepancy between diameters of the left main and the ostium of the LAD, I think mandatory use of imaging should be strongly recommended, as stated also in EBC consensus documents. However, DK crush is currently the best validated two-stent strategy for the left main, and we still await for the results of the European Bifurcation Club main. It's the study comparing randomized comparison of single versus dual stenting strategy for true bifurcation left main coronary lesions, and we intentionally used, because of this discrepancy in diameters between left main and the LAD as well as the circ, we used Resolute Onyx stent, which is now CE marked to expand additional 0.25 millimeters across the side matrix from 2.0 to 5.0, and it's purposely designed for extra large vessels like the left main, with 4.5 and 5.0 diameters now being able to expand up to 6 millimeters. And 2.0 millimeter design also can expand up to 3.5 for tortuous and tapered extra small vessels. I'm happy to share with you that study recruitment is completed on December 1st, 2019. So I would like to congratulate the top 3 recruiting centers, and we really await February, March next year to see the results of this important study and to understand if also in European centers DK crush and two-stent strategy performs better than provisional. I would like to invite you also to attend Bifurcation Exploration website, and you can access all those nice images from the Visible Heart Lab, as well as step-by-step description of all contemporary used bifurcation stenting techniques. I thank you very much for participating in this webinar.
Okay, welcome to the Boston Scientific Symposium of EBC Live 2020. As you can see, the three of us are live, so we're not recorded. That gives us extra opportunity to make this symposium interactive. What we plan to do today is to talk a little bit about the optimal left main trial. That's a randomized trial of intravascular ultrasound in the left main. We've been hearing through the meeting today how important imaging is in improving our left main results. And this trial is a randomized trial sponsored by Boston and by Philips. And the three of us, Chima, Luca, and I, are the PIs of the investigation. I'm pleased to say the trial has survived and fought past COVID and is already recruiting, particularly in Dr. Tester's lab, who's been an absolute star in recruiting cases. So in the next 30 minutes, we're going to discuss some of the rationale for the optimal trial, and we're going to discuss some nice cases that Luke has got to show us. We're going to start off with a talk from Chima, who's going to talk to us about IVUS guidance to the left main, why we do it, and how we should do it. Chima, thank you very much.
Okay, thank you, Adrian. I'm going to share my screen to show the presentation I have here. Let me see if this is the optimal. This is the slide. Can you see properly the slide?
Yeah, that's correct.
Yep, perfect. Okay, as Adrian presented, we are talking about the main PCI and particularly about IVUS guidance. And before just dealing with cases, and I'm going to do some introduction and talk about the rationale for optimal. No? We need to optimize the most result of the PCI in the left main. We have been living like a storm in the debate between PCI and surgery in left main disease, and it's truly very important to optimize by our side from the PCI perspective the results. And intravascular imaging plays a crucial role in this objective. IVUS is going to be really useful because it's helpful to plan the strategy, to prepare the plaque, to size the devices that we are using during the procedure, and finally to optimize the results by assessment of expansion, apposition, stent edges. For example, the selection between provisional and two stents technique can be done with the use of imaging. For example, we have here the criteria for IVUS. If we examine the circumflex and we see MLA over 3.5, low pearl burden, we can go to provisional. But if the circ is an important vessel with less than 3.5 lumen and more than 50% plaque burden, we should maybe go for two stents up front. In this case, with this very complex distal lesion and geographically very difficult to discriminate, it's very clear the disease in left main, LAD also involved, but CERC is mild disease, so we go with provisional for 16 LAD to a left main and pod with 5 millimeters and good result. This other case is a distal left main with proximal CERC severely affected. With IVUS, we can confirm the distal disease of left main, but LAD has a lumen over 6. Then in this case, we are going to provisional, but from CERC to left main in this case. This is not the most common, but sometimes happens. 328 and then pod with 4 millimeters and the result is very good. On the other hand, we have cases like this, very complex distal left main with involvement of everything, distal left main, ostial LAD, ostial CERC. So two-stent technique is the choice in this situation. Stent size is very important, and geography always underestimates. We can, I provide, for example, this is out in our study we published in Neurointervention this year regarding the strategy for sizing in ostial and mid-shaft in distal for provisional or in distal with two stents technique, usually based in the reference lumens in all cases. For example, this diffuse left main lesion, particularly distal, we size here the stent. This is the lumen of LAD 3532, then the stent should be 3.5 millimeters in diameter. In this case, I showed before, we have this left main here reference. The distal is involved, but the proximal is more healthy. Here is for 1, and in CERC is 3. So the stent is going to be 3 millimeters in diameter, but the pod should be done with 4 millimeters. In this distal lesion with more complex involvement, the reference lumen in the LAD suggests the use of a 4 millimeters stent, and in the CERC is 3 millimeters the reference. So we are going to select two stents for this two-stent technique, 4 millimeters to LAD, 3 millimeters to CERC. And IVUS makes a difference in sizing. We have the experience that with IVUS, you usually select a larger stents, as we can see clearly here in this data from a huge number of patients, but also we dilate more with larger balloons. Optimization is the next step. After sizing implantation, we need to optimize. These are the different steps we follow and the different criteria we have established. You can really find out this criteria in the publication, but I'm going to be in detail with the optimal. The optimal trial has this very elegant set of criteria: a position expansion, dissection in the edges, lesion coverage. And I'm going to illustrate with these drawings. Dissection, we tolerate those that are very short and very small in circumference. For complete apposition, this should be very short and very small, less than 0.4 millimeters. For optimal expansion, we have established a mandatory criteria, which is to be over 5, 6, 7, 8 for the minimum stain area in the corresponding circle, LED, POC, and the main, or the desirable targets of more than 90% of expansion with respect to the luminal area reference in lead main, LED, or circ. For example, in this case, we implanted a 3.520. We did the pod with 4, but even with that, we have this huge malapposition that angiographically is really not appreciated. And then with 5 millimeters, we have a good apposition. This is a stem, circ to lead main, and not good expanded initially. It's only 7 square millimeters, but after good expansion, we get much higher, 9.7 square millimeters. In this complex distal lead main lesion, we treated with 2 stents, with kiss and balloon, with repot. We could see that in the intermediate step, the expansion in the distal lead main was not optimal, 76%, but we corrected this to 97% with the IVUS control. I can tell you that with angiography, these are the subtle differences that you cannot really distinguish. We have, in this case, a full lead main coverage, symmetry neocorina, and expansion over 90% in LED and circ. Meta-analysis show consistent benefits for IVUS regarding MACE, but these are registries, no, and it's important to move forward. In the Excel trial, another hint was that the comparison between high and low tertiles of minimum stain area showed a very different outcomes at 3 years in favor of the larger lumens. In the novel, again, the IVUS guidance was associated with a trend for less MACE, a significant decrease in TLR, and the comparison between tertiles, the higher and lower tertiles for MSA, a significant difference in, very huge significant difference in TLR, and an important trend in MACE. The British registry, Adrian is one of the co-authors here, and they analyzed a huge number of over 11,000 patients with lead main stenting, no imaging 6,000, imaging 5,000, this difference in mortality with an independent predictor role for IVUS in analysis. We also have shown this slide several times that showing that the use of predefined optimization criteria for IVUS increases the chances for less outcomes, improves the prognosis of patients undergoing PCI of the lead main. So we have so far this recommendation 2A, but we need to move forward, and the trial, the optimal trial, will be very important. Over 800 patients to be randomized to IVUS or angiography. Luca is enrolling so far nearly 20 cases. We are much lower with 3, but we are going for sure to accelerate and to improve the enrollment. It's not the best time with the COVID thing, but we will do our best. Then I was imaging for lead main disease is definitely helpful to evaluate the extension of disease, to characterize the plaque, to plan the strategy, to guide the preparation of the plaque, to size the devices, to optimize results. And this is really good for patients and good for the prognosis. But the optimal trial will bring the ultimate evidence. Okay, thank you.
Kima, that was terrific. Thank you. Boston's recently brought out an HD IVUS catheter. Do you think it's given us better quality pictures, which are now sort of comparable to OCT?
I showed here one case that I did with the HD Boston IVUS, and I can tell you that it's really great. It's competitive, definitely, with RCT in the resolution. At least the resolution we need, of course, because it's not able to reach the 10, 15 microns of resolution, but we don't need so much. With the HD, we have enough resolution, and what is good, we have the complete vessel picture, because the penetration is still IVUS-like. This is important compared to OCT.
One of the reasons that people say they don't do IVUS pre is because they're worried that the patient won't tolerate the intravascular ultrasound imaging. what percentage of cases do you not do IVUS on because you're anxious and the patient won't tolerate it? Is that a big number or a small number?
No, maybe if when the lesion is very critical and the patient is in a bad condition, it's true that what you have to do is immediately open with the balloon, the lesion. But once you have the patent and open the left main with the less critical stenosis, and you have the hemodynamic stability, you can really do IVUS, or at least you can implant the stents and to check the stent result with the imaging. But you are right. Maybe in I don't know, 10-20% of cases, I don't do IVUS baseline because the lesion is so tight that it's not really a good thing. But just to optimize, maybe I do in all of them because I think it's possible and safe.
Get the patient into a safe space and then image, and then
Yes.
get back into this kind of more slow, careful approach rather than this kind of rushing and trying to get the case finished over quickly. That's been fantastic. Thank you very much.
Thank you.
Well, Luca, I think you have some cases to show us. We're looking forward to it. And we'll perhaps ask Chima to give some comments as well once we see the cases.
Sure. So let me share my screen with you. Okay. Just a second to optimize sharing. Okay. Okay. I hope that you see what I see. Do you?
Yep.
Okay, good. So, well, just let me say for a few seconds that it's always a pleasure to share some time with you guys, and I mean it's also a pleasure to to share a couple of cases that I did in the last few weeks, and I hope that I'm gonna speed up the process even more. I'm not sure because mala tempora currunt, as the Latin says. Anyway, that's the case number one. 65 years old man with family history of coronary disease, angina with progressive reduction of the exercise tolerance, and a treadmill test positive for both signs and symptoms. Echo normal parameters, nothing special. Mild stenosis of both internal carotid arteries, and then admitted for coronary angio. So the right coronary didn't receive much attention, a lot of calcium, but nothing really important. But the left main, of course, was a bit of an issue. And in this other view, you see there is actually also an involvement of the LCX in osteoproximal part. So that was the syntax score, because of course we need to discuss, we need to sit down, we need to schedule the patient and see what is the best approach for this. I have to say that our team discussion was pretty useless, because the patient, a physician, by the way, firmly refused the surgical treatment, and he's actually a general practitioner working very close to my hospital. So there was no way to discuss with him. He said, just go with a stent or whatever, no matter what. Okay, that's good. Anyway, I would like to show you again a couple of pictures, a couple of movies actually, to discuss with you. So what is your strategy in this? Of course, you may think one stent, two stent, DK, culotte, tap, mini tap. What is your approach?
Chima, do you want to give us a comment?
Yeah, I am trying to figure out with angiography the osteon of LAD and CERC are involved. It looks that the osteon in CERC is more diseased more affected than the LAD osteon. In the projections, the disease is in the distal main, but the ostial LAD, of course, LAD is a bigger, important vessel, but the CERC is not really a small vessel. And I think we need some imaging or something to see what's going on with the osteon of CERC and LAD, because if one of them is well preserved, we should go with provisional
Okay.
LAD or CERC.
Oh, let me just say that for the sake of time, I didn't include in this presentation all the movies, but I can confirm what you just said. The lesion is particularly critical in the osteal LCX, but it's also significant in the LAD. Going back to the concept of IVUS at baseline, in this case, actually, I discussed with colleagues what to do, and with the colleague on the table, and I said, look, I will open up very quick, and then we'll decide what to do next. And yes, I have to say that it was not the case, because the patient destabilized immediately, as you can see from this.
Yep.
And so it was absolutely needed to put myself and the patient in a safe spot. So that's why I used this impeller, and then I actually went to the femoral approach. But anyway, so that was the situation. Sometimes happens. But anyway, putting the impella actually put everything else really, really in a sweet spot. And my decision was to go straight to predilation, as we said before, you know. I mean, if you try, and we said that already, if you try with IVUS, you may destabilize the patient. And in my practice, I always do IVUS post, but I would say in a third of the cases, I don't do IVUS baseline. That's my approach. Of course, it's questionable. Anyway, this is what happened. So semi-compliant balloon, 2 millimeters to the circumflex to open up and give some flow. And then semi-compliant balloon to a 2.5 as a predilation in kissing balloon technique. And then a non-compliant balloon 3.5 for the left main. This is the result of the predilation. So you see that, you know, something good has been achieved already. And I would like to show you again this specific one over here. For some reason it stopped. Anyway, at this point, what is your strategy?
So I think the interesting thing is you do seem to have got balloon expansion. The other question I was going to ask was about the use of rotablation or lithotripsy. There's quite a bit of calcium there. And I think you're in a, you know, the key question, of course, is whether we're looking still for a 1 stent or a 2 stent strategy. I think for me, this is probably going to end up being 2 stents, but what do you think, Chima?
Yeah, I think LED is pre-dilated, then the osteon has been touched. And now you could do IVUS because you have pre-dilated lesions, but you have a space to see if the calcification is really worthy of some plaque preparation. You have the impella, and maybe a patient is more tolerant to a shock wave, for example, balloon, I don't know. But anyway, it's important to have the hemodynamic stability and now to do the plan more calm conditions.
I can tell that, of course, the patient was absolutely stable from an hemodynamic, from an hemodynamic point of view. I mean, the impella is great. I don't know what is your experience, but in my practice, when I try to use it and I use it, well, it's I never regret. Yes. Sometimes probably is not needed, I have to say. Yeah. And there is also a kind of a vogue nowadays. I use impella, whatever. Anyway, when you use it, you never regret. At that time, at that point, the patient was, you know, absolutely stable. But of course, he started to complain. Okay, is it taking long time? Blah blah blah. So forth. So my decision was to go straight to stenting to the LCX. And this is obviously questionable, we will discuss this, but that's what I did. And my intention was to go with a 2 stents technique with minimal protrusion to the LCX. I want to discuss with you this choice, in particular looking at the angle of the LCX. If you look at the angle of the LCX, I believed that it was absolutely suitable for kind of a T-stenting. Of course, guidelines and you know, experts, they suggest the DK crush, they suggest some more complex approaches. But I have to say, in that case, I felt very comfortable to start doing this kind of technique. What do you think?
It's true that the angulation is close to 90 degrees, which is good for T, and you don't have the complex of a lot of metallic thing in the distal main at the end. But the difference is, for example, culotte is going to be a problem because Serruys is much smaller than the main. Then I think T or TAT would be the best here.
I agree with you. I mean, I have to say that I'm personally a fan of culotte technique, but not with this discrepancy. I mean, the left main is huge. The LED is relatively big. The circumflex is, you know, it has a big territory, a big volume of muscle subtended and supplied by LCX, but it's not that big. So I decided, okay, let's keep it safe. The LCX, I just want you to remind that the LCX was badly diseased at the beginning. So I said, look, put the circumflex in a safe spot. And then I use a Megatron for the LED left main across the LCX. And these are the pictures. So the first one I chosen, actually I thought it was enough because my first intention was not to reach the osteo left main. This is also questionable. What is your practice? Do you always cover the osteo left main?
Well, the original data from France was very sort of persuasive that that's what we should be doing. I think the subsequent data has suggested if the ostium of the main is not diseased, you don't have to cover it, particularly when they're big. I think you sometimes create a problem, then trying to get apposition of the stent. In a case like this, I probably would cover it as long as I'm confident I can get across. It does look as if there's a little bit of ostial narrowing, but as you've shown nicely in the LAO-cranial, if you're going to cover it, you cover it. You don't just miss it. So you've got to make sure you get it right.
Yeah, I have to say that usually I cover the ostial left main when, you know, the disease is diffuse, even when there is, well, non-significant plaque, I tend to use it. However, when I have space and the left main is really tapered because the ostium is very large, very big, I try to avoid this approach. But of course, I got no data to say that it was the right approach, but I have to say that the initial result actually convinced me that it was not a good idea, and I'll show you in a second. So after stenting the left main LAD, I did a kissing balloon, like, as usual. That's obviously mandatory, and that was the result. But if you look in LAO-cranial, Adrian, you understand that you were right. You see? I hope that you can see. So, I mean, leaving few millimeters of the left main, and geographically speaking, was actually not acceptable. So I said, look, okay, we still have time. Patient is fine. Everything is under control. So I will put another stent. And it was a Megatron 4.5 by 12. And I think that, I mean, this injection confirmed that it was absolutely, you know, in the right place. Non-compliant balloon 4.5. I didn't do again the kissing balloon, but just the POT, because of course I didn't involve the distal left main, so 4.5. But that moment, of course, I did the IVUS, and I would like you to comment this. I mean, that's the first run from LAD left main, and I will let it go. It's not very long, so we got few seconds. But as you can see, there is a full apposition, nice apposition. That's the left main, and you know, there are some numbers on the right side of the slide, and I guess it's I mean, it was okay. Do you want to see it again, or just go?
Probably
Okay,
in the interest of time, Luca, we should just keep going, I think.
Okay, that's the LCX, and I will show you just in a second. But anyway, this patient has been enrolled in optimal, so we made the calculations to make sure that the criteria were met. They were met, so that was the end. I used the Synergy Megatron for some reason that you know, but I mean, since I started my practice with the stent, I have to say that it became my workhorse for left main, in particular for two reasons: the increased overexpansion capability, but also for the uniform lesion scaffolding. I mean, it's really crucial for the left main, and I have to say that even outside the trial, I'm very happy to use this device. We were talking about the HD before. I did some cases with the HD since, you know, for a few months. And I have to say that the difference between the HD and the normal one is actually 40 megahertz. I mean, is significant. And I agree with Cima when he said, look, this is something that can compare to the OCT. It's not like the resolution of the OCT, but definitely is a big step ahead. Okay, let me just show you the final angel. And I have to say, I was happy, patient was happy, and I mean, he'll come back in a month for a clinical control. Case number 2, 58 years old man, former smoker, hypertensive, dyslipidemic, recent episode of breast angina, and treatment test positive for signs and symptoms, so sent for coronary angio. Again, the right coronary, you know, not really interesting. The left main is the problem here. But not the left main, not just the left main. As you can see here, there is a bifurcation involved, and in RAO caudal, you see much better, okay? Syntax score, even in this case, 24, but I have to say, I'm showing a second case where this patient, but not a physician, just said, do not cut my chest. I will never accept this. If you can do the bite stent, just do it. Okay, I said, look, I will, no problem. So what is your strategy?
My view, as I say always to my fellows, that the ostial disease is a left main disease, always. There is plaque in the distal left main. What happens is that here the plaque is more concentrated in the ostium of LAD, but there is, which is severely affected, and the proximal LAD. And so the ostium of Serruys should be evaluated, because maybe the provisional is the best here to LAD, left main LAD, and then to check the Serruys afterwards.
think you have to remember how much disease it takes to produce an appearance like that. You know, it's easy for us to forget. There's an awful lot of atheroma around the ostium of the LAD there, which must inevitably involve the terminal left main. But I would agree with Chima. I think they're also trying to get a measure of what you think the size of the LAD should be. Imaging would certainly help you there.
Yeah.
But you're going to be moving quite a lot of plaque. But I think you may get away with a single stent crossover into LAD, I think.
Yeah, okay. And I have to say that obviously I agreed. So again, this was a matter of time. In that case, patient said, again, complaining, jumping on the table and so forth. I mean, it was quite a lot of fun, I have to say, that case. Anyway, a lot of fun. So I said, okay, go quickly, good. 2.5, 3.4, and non-compliant balloon. So I just made sure that the lesion onto the proximal LAD, I'm not sure did you know this, but it was subocclusion. Actually, I fixed it with a synergy 324, it was okay. I post-dilated with a 3, it was fine. So at that time I said, look, I got a big dissection. I hope that you can see in the proximal LAD and left main. You see that?
Yeah.
It's visible in LAO. Okay, good. So look, the fellow very close to me said, look, let's do the IVUS. Yes, sure. With the dissection left, let's do the IVUS. Yeah, it was a very, very nice call. Anyway, said, look, let me put the stent and then we will discuss for the rest of the afternoon and then we'll do the IVUS every time you want. Anyway, so patient was going down. So I said, look, I will put a stent. I will secure the situation and I'll post-dilate. I'll do the kissing balloon, men's side, and then we will check. I would like you to have a look at this. Of course, the numbers are on the right. And in this case, I mean, this patient has been included in the optimal trial. So this is a different IVUS, as you can notice. This is Phillips one. So the shaft of the left main was not good, but also the MLA calculated to the LAD was not good. So according to what is, in my mind, best practice, perhaps is obviously our aim for the optimal trial, I needed to post-dilate. And so I did. 4.0 millimeters non-compliant balloon to the proximal and ostial LAD, 4.5 to the left main. And I did IVUS again. That's the left main, that's the ostial LAD. And it changed significantly. For the sake of time, I just skipped the entire run just to show you what it was and what it was at the end. MLA, 11 millimeter square, and LAD 7 millimeter square. I would like to have your opinion because 7 millimeter square to the ostial LAD is something that, nothing to cheer about, but it's acceptable, it's good. I believe that with that huge plaque burden, 7 millimeter square, it's something you must accept. But, I finally achieved a good apposition, as you can see here. It's okay. I mean, angiographically speaking, you will never say that you could do, something even better than this, I guess, on the proximal LAD. However, it was 7 millimeter square, so it's not huge. What do you think? Would you have stopped here or not? I stopped. I say in
I think if you've gone at high pressure with a 4 balloon, I'm not sure what else you're going to do, really. There doesn't appear to be a lot of calcium. I don't think, lithotripsy is going to help you further. So you're really going to be going for a 4-5 balloon, and then you perhaps run the risk of starting to compromise the circumflex. So I think you've got a very nice result with one stent, and I think there is a benefit from that in this case. Perfect is the enemy of good, and
yeah, I agree. Yeah. Indeed, I was actually in the mindset of getting out of the lab quickly, making sure that all the IVUS goals were met, and also I asked myself what to do next. I mean, even if I take a bigger balloon, what is the point to achieve 8 and maybe I compromise the ostial LCX and then I have to put the stent on LCX? I said, look, best is the enemy of good, as you said, Adrian. Yes. And I think it's okay. It's okay.
The cutoff value for LAD and in the Excel trial was around 7, which is, you are right, you are in the safe point. And in general, it's 6 square millimeters, the cutoff for stenosis in vessels, not the main vessels like LAD. The Serruys, if you have any doubt, you can do one-day pressure wire to check if the Serruys has some flow compromise, but not at this moment. This is perfect result for this procedure.
I think it was okay. Thank you for saying it's perfect. But what I think at the end is, I mean, the take home from these two cases that should be part of the routine. We are saying that since the beginning of this meeting. Pre-specified IVUS goals are paramount. I mean, Chima made a very, very nice presentation. I mean, we need to have a goal. Otherwise, it's just a way to show off ourselves. Indeed, IVUS data must be actionable, absolutely actionable. And in the first case, of course, it was not needed to make additional actions after IVUS. But in the second case, it was absolutely mandatory to react to the IVUS numbers. And let me say that the optimal trial has been designed with this purpose. So we'll see in the future what we can get. And thanks for your attention.
Great, Luca. I mean, I think
you.
It's also particularly important, and when we're moving into these younger patients, you know, one was a 65-year-old, one was a 56-year-old, I think you said, that we spend the time to make sure we've done everything we can. Now, you know, the reality is we can't get a perfect result all the time, but the fact that you spent some time making sure that you know, you've got about a 30% increase in the proximal LAD area. That's going to be important for this guy. And particularly, you know, when you're in your late 50s, as some of us are, we can still occasionally go for a short run or something like that. And we need to, you know, our coronaries need to be as big as possible. So I think that was a really great result. So this has been a short seminar. We're grateful to Boston for their support. I think what we've seen is how using the HD IVUS technology that Boston now has, combined with the Megatron stent, with the properties that the Megatron has, how we can improve our outcomes, not only really in the elderly patients where, you know, stents may not be maybe the only option they have, but also in these younger patients now, we're really getting a fantastic result, which gives them a lifetime, hopefully free from angina, has got to be our goal. So we look forward to completing the trial, and we look forward to the rest of EBC Live 2020. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Bye-bye.
Hello, good afternoon. And first of all, thank you for the opportunity to be part of this imaging session, this EBC 2020. It is my pleasure to co-chair this session with Dr. Murasato and Dr. Johnson. And without further delay, I'm going to introduce Dr. Johnson. This talk, should imaging be undertaken for every case? Imaging session, this EBC.
Dear colleagues, Chairman, thank you for this opportunity to present this afternoon on the role of imaging in left main. This has been a fantastic EBC despite the challenges that COVID has thrown up. So I've been tasked with looking at whether we should be using imaging for every left main intervention. My name is Tom Johnson, a consultant cardiologist working in the UK in Bristol. These are my disclosures, and I would like to thank Tim Kinnaird, a colleague from Cardiff, who has kindly shared some slides that have been adapted for this presentation from our work done from the British Cardiovascular Interventional Society audit dataset. So I think the first thing to acknowledge is that with regards to imaging in PCI, we seem to have fairly polarized camps of practitioners. So on the one hand, we have those that would say that they have IVUS eyes, they've done enough imaging to know how their interventions proceed, and therefore they don't need to be using imaging. And then interestingly, in left main, we then have another camp who say, I always use intervention. There is no way I could go without. And so, you know, we have to then question, when we have such diametrically opposed opinion, where the truth really lies. If we firstly look at the I always camp, well, you know, the UK data would suggest that not everyone gets imaging for left main. And although we've seen an increment from 2007 to 2014, from 30% of cases to 50% of cases being imaged. Clearly not everyone is. Now that might be still that we have operators that do always and operators that don't, but I think really there's probably a balance reality. If we then consider the camp of those that don't image, then the statements that we often hear in support of this are, well, I've learned from experience. I've done so many of these that actually I now know how my devices behave. Or perhaps there's a justification that through adhering to the EBC mantra of POT, final kissing balloon, repot, that actually if doing that, then there isn't really the need to consider further optimization by imaging. And then often we hear that imaging incurs unnecessary cost financially and cost of time. And then also that actually my outcomes are good. Why do I need to be enhancing it further? Imaging is perhaps for other operators, lesser volume or lesser experienced operators. And so often I think these are the statements that we hear in justification for not using imaging in left main. Actually, if we turn to the reality, even if we look at the most contemporary data, so Excel 5-year data, now here presented 3-year outcomes in terms of death, stroke, MI, and ischemia-driven revascularization. And this is a really nice subgroup analysis by David Kanzari, looking at just the PCI population, those that had provisional 1 stent against those that had planned 2 stent with the dotted line. And we see that clearly the more complex intervention carries a greater hazard. And I would really argue that, here, even where imaging was used in over 3/4 of patients, can we really suggest that a 30% event rate at 3 years is a good outcome? And I would suggest not. This is not adequate. Now, the response to that would be, well, we've moved on, in fact, from Excel, and we now have DK crush. That's the answer. We hear everyone saying DK crush must be the method that we use. And obviously that does stem from the very powerful data from Chen demonstrating this benefit of the role of DK crush over a provisional in the DK crush study that has already been expanded upon during this year's meeting. But I think then if we consider clear comparison, unfortunately not all endpoints are directly comparable, but if we look at the 3-year outcome of the XL2 stent data that I've shown from Kanzari and the DK crush 5 cohort, we see that there is an excess of all-cause death in XL. Myocardial infarction, it's reported all versus target vessel in the DK crush 5 cohorts, but we see a striking difference in terms of myocardial infarction. Target lesion revasc is defined either as ischemia-driven revasc of the left main in XL or TLR in DK crush. And again, there's a striking difference there. And there's at least a halving of definite stent thrombosis reported by DK crush 5. So perhaps maybe, DK crush is something we should be considering more in the left main stem. But the only caveat there, again, would be looking at the original inclusion of operator or inclusion of sites for this study. Operators needed to be performing over 300 PCI a year for the last 5 years, and they needed to be undertaking 20 left main PCI per year. And interestingly, when we look at how they went about their interventions, imaging didn't really play a major role. So pre-procedural IVUS was undertaken in just under 1/3 of patients, and overall IVUS was adopted in about 40% of cases. So maybe it is procedural expertise, volume that defines this. Now, reverting to the UK data set, which I'm more comfortable in kind of justifying, then this is the data from Tim's work with the BCIST audit. And we see that, interestingly, in terms of use of imaging, there are differences according to operator case volume, with a gradual increment with increasing case volume until we reach the highest volume operator group, where interestingly we see this drop off again in imaging usage, perhaps again indicating that IVUS eyes exist. And we see across the span of the 8 years of assessment that IVUS is by far and away the most commonly used modality with a slight creep of usage of OCT over the last 4 or 5 years. Now, looking specifically at operator volume, Tim and Adrian and others have published really nice work again this year, looking at this BSIS data set. And we see that, you know, the vast majority of UK operators are undertaking less than 10 left mains per year. And in fact, if we look at the quartiles, quartile 1 has a median case volume of 2 left main, quartile 2, 5 left main, up to 21 median cases undertaken in the highest quartile. And so if we reflect back on the DK crush experience, that would suggest that really there are only 11 operators in the UK that could have participated in the DK crush study. But importantly, when we consider operator volume against the outcome, here you see quite clearly that the highest volume operators have substantially improved outcome. Here, the cumulative incidence of events just over 5% versus 12% in the cohorts with less experience. And that's true for in-hospital Mackie. We see this gradient from lowest volume to highest volume, this decrement in Mackie rate, mortality in hospital. 12-month mortality, really the only difference is seen in the highest volume operators. Peri-procedural MI, procedural complication rates, we all see reduce with experience. And so there does clearly seem to be some benefit in terms of increasing experience. Maybe though, if the majority have lesser experience, you know, imaging could be used to overcome this volume deficit. So if we return to the BSIS imaging data sets, then we see interesting associations in multivariable analysis. So interestingly, imaging was adopted more often in patients undertaken via the radial access, possibly indicating, you know, a younger cohort or those more willing to adopt contemporary practice, being those that will engage in imaging. We see that the more complex bifurcation anatomy made it more likely that imaging was used. A stable presentation, and again, this acknowledges that the more kind of complex, the sicker patients maybe aren't appropriate for imaging. It's an interesting observation about trainees being the first operator. We think that most likely reflects the fact that these are procedures being undertaken in higher volume university or tertiary centres. And yet we see that the sicker patients, again, those who've had previous intervention with lower ejection fraction or more complex disease, are again less likely to have imaging use, where perhaps imaging would be more useful. And then if we look at the outcomes from the use of imaging, then again we see this reduction in complication rate. Importantly, no difference in acute kidney injury as a consequence, although OCT was used in a very small minority of cases. And we see these stark benefits to outcome in terms of in-hospital death, Mackie, mortality at 30 days and 12 months. And this is nicely demonstrated in this Kaplan-Meier plot, showing an absolute reduction of 4% in mortality at 1 year, a 30% plus reduction with the role of imaging against NOT in unprotected left main stem PCI. How does this compare? You know, UK data against other centres. So if we look certainly European data from the Swedish SCAR registry, very similar outcomes. Jose is going to talk to us about the role of IVUS in relation to left main. And then we see more global studies from Southeast Asia, all demonstrating this clear benefit of the role of imaging against angio-guided intervention in this complex group of patients. So in conclusion, should we be using imaging for every left main? Well, kind of West Country saying would be yeah, but no, but. Well, imaging clearly is associated with improved patient outcome. Although I think it's important to concede that not all left main PCI can be image guided, I would argue that most cases should be image optimized. So the sicker patient, we may not be able to use imaging up front, but we certainly should be adopting imaging towards the end of a procedure to confirm an excellent result. And I'd actually turn this back to the panel with another question, which is an important one, I think, from the data I've shown, which is, should all PCI operators undertake left main PCI? So we've seen clearly this relationship between operator volume and outcome, and it does make you question whether it should be an increment in imaging or maybe more guided selection of operator for procedure that we need to consider to improve outcomes for our patients. I thank you for your attention.
Well, thank you, Tom, for this excellent talk. I'm going to introduce the panelists we have with us to start with the discussion. We have Dr. Frenstedt, we have Dr. De la Torre, Niels, Dr. Lefèvre, Nicolas Amabile, and Gabor Top. I think there are two factors. You pointed to factors that improve outcomes in left main PCI. These are volume and use of imaging. And what is interesting is also the relation between these two factors. You clearly showed how experienced operators also use more IVUS. So this idea of if you are very experienced, you have done IVUS in the past, you have these IVUS eyes, you don't really need to do it anymore. I think these data show that probably most experienced operators, they use more IVUS because they understand that there are some factors that you cannot really see in angiography. I mean, you can have some, you can use this previous experience, for example, to size your stent, decide about, for example, size of both balloons, etc. But because you know that the size of the left main should be around this, because of your previous experience with IVUS, but of course there are some aspects such as, for example, underexpansion, focal underexpansions, etc., that can only be seen with imaging, and these are actually the ones influencing the outcomes. So what is your opinion on this relationship between these two factors, volume and use of imaging? How do they interact?
I think that the experience tells you at the end of the day that angiography is misleading. And is this something that you learn year after year doing many cases? And then, even though you have maybe 20 years or 25 years doing left main PCI, not left main PCI, but PCI, you have the conviction with all this time that angiography is not enough. And you cannot distinguish a 75 to 90% expansion stent just with angiography. You cannot appreciate malapposition with angiography. And then in the left main, this is critical. These outcomes are important. It's very sensitive to these differences between 70 and 90% expansion. And angiography is not enough. This is something you learned. And that's why there is a apparently paradoxical relation between volume and the use of imaging. But I understand it's this way, at least for me.
Yeah, Dr. Frenstedt.
Yeah, one comment from the EBC would be that we have tried to put it into the consensus based on all the discussions we have had in the earlier meetings. And of course, we promote all we can imaging because it optimizes most of the procedure, in our opinion. But in the statement, we said that at least it should be used if a procedure proceed in a way that is unexpected. So it's actually two things. So. But it is important because it means that if you have access to imaging, then you also need to use it at a very, very low level of need.
Jens, then the counter to that is that you say the unexpected. And I think Jose Chima would indicate that the more you use imaging, the more you realize angiography is unexpected. We can't anticipate what the angiogram tells us. And then we had a statement yesterday from Yves Louvard saying, well, it's not reimbursed, and so we can't use it. So the French experience, and maybe we turn to Thierry, is that if it's not reimbursed, then we can't really use it. So although you might acknowledge it makes a difference, your hands are tied. So I don't know where we can get to. I mean, the consensus statement is a consensus statement. It's not mandatory. So Thierry, I don't know how you overcome those challenges in a place where you can't reimburse.
I think it's not a good argument to say it's not reimbursed, so we should not use it. We start doing left main in the 80s in France. And we have done IVUS in all cases for many years. And then we start to learn what we should look carefully. And you see bad expansion of the stent. You see that the stent is not at the right size. You know how to size the left main, and it's very difficult with IVUS to make a good sizing. when you have a lot of positive or negative remodeling. So it's not so simple. And I think you gave the answer by yourself with the paper of Kinnaird. You are the second author of this paper, which I think is very important. And you said that maybe IVUS eyes does exist. You said that just before. And because when you look at the 4 tercile of the result, they use less IVUS and they have better result. And then when you look at the 4 curves at 1 year follow-up, the people who are in the 4th tercile have the best result as compared to the first one, the second one, the first 3 one, which are really in the same direction.
Yeah.
So it means just that these people who are in the 4th tercile, they use IVUS only when they think that they should use it, but not in all cases. And this is what we're doing in my center. So when there is something which is not clear, there's something which is going wrong, you are not happy with the final result, we do it. But because we have done more than 1,000 left main cases since the last 20 years, we do 300 left main cases every year. So,
but Thierry, then you're bringing us back to this argument of volume, because you know, clearly the upper quartile are undertaking 20 plus interventions a year, which matches the DK crush experience, but it doesn't match the reality. Yeah, if you look at the BSIS data, I didn't show you the dot plot, but the majority are doing 5 cases, 2 to 5 cases a year. And so clearly we need to use then imaging to bring the quality up.
I push the idea of compagnonnage. So if you are doing 3 or 5 cases a year, you should do it with somebody who has a lot of experience, because you are learning a lot with this approach. And this is going like the Xubo study, who showed exactly the same as the Kinnaird paper. So when you look at by multivariate analysis, what is strong is experience of the operator, more than 30 cases a year. And then IVUS is not a predictor in multivariate analysis, just because a lot of people were doing a lot of cases. But of course,
we'll see what the next couple of presentations show us. Yeah, okay.
Okay, yeah, I think we can maybe move to the next presentation by Dr. Jose de la Torre Hernandez. Should IVUS be preferred to OCT? Sema.
Hello, it's a pleasure for me to participate in EBC Live 2020. I am Dr. Jose Maria de la Torre Hernandez from Spain, and I'm going to talk about why IVUS is my favorite modality to guide late main PCI. Disclosure, IVUS is definitely important in the diagnosis and intervention phases dealing with late main. It's very helpful for assessment, for guidance, and for optimization of late main procedures. As we know from the guidelines, IVUS has a 2A class recommendation for assessment of ambiguous late main lesions from the point of view of angiography. Angiography is not good for the characterization of the severity of late main lesions. Definitely, you can see plotted here the stenosis against FFR or against the intravascular lumen, and there is no good correlation. Angiography is not definitely very precise. We have proposed 6 square millimeters as a threshold value in late main lesions, and these scans run correlation with FFR. It's coming from physics like linear low, but also from the LITER study we conducted in Spain years ago. In this multi-center study, we demonstrated that the deferral of late main lesions with lumen over 6 was saved, and the outcome of these patients was comparable to those patients with less than 6 square millimeters undergoing revascularization. The minority of patients between 5 and 6 and no revascularization and deferral revascularization have a poorer outcome. This is a pool analysis comparing the outcomes of deferral patients when using IVUS or FFR in late main assessment, and you can appreciate that the per year follow-up occurrence of viral mates is quite similar. So this means that both techniques can be used to assess the late main significance. Of course, out of the late main is just a field for a pressure wire, but in late main, IVUS plays or has a role. The consensus for the use of imaging that was published in the European Heart Journal last year is very clear and provides very meaningful protocols like the one shown here, when you can see how when we approach these intermediate lesions, when the lumen is over 6, we can defer. When the lumen is less than 4.5, with revascularized main lesions, and then the lumen is in between 4.5 and 6. Pressure-wide assessment is recommended to make a decision. IBUS is definitely helpful to assess LAD and CERC osteoid distal main disease, because angiography is not good for this purpose, as we can see in this table from this study. And main distal disease implies many times involvement of in a different degree of LAD and CERC, and IBUS is gonna be really important to establish how is the extension of disease to the different osteoids. IBUS also unmax angiographic artifacts that are not really uncommon and sometimes can lead to an inappropriate diagnosis and interventions, like in the cases we show here. But also important is the plaque morphology and composition assessment that IBUS allows in the left main lesions regarding calcification, regarding, for example, in this case, is calcification, showing annulus, showing nodules, showing different disposition of the calcium, and then to provide some guidance for plaque preparation. But MPCI is associated with an accrual of heart events. We know these very well from trials comparing left main and cabbage. And we need to optimize the most the results of the PCI in the left main. And among the different factors that are listed here, I think the use of intravascular imaging, IBUS specifically, is very important. IBUS is helpful to plan PCI strategy, one of the stents for guiding the preparation, assessment of calcification, the device sizing, not only the stents, but the balloons for dilatation, the balloons for pot, and finally optimizing results, assessing the expansion, the lesion coverage, the position, the stent ages, the distal stent ages and the proximal stent ages for the dissection, plaque hardening, and the stent deformation in the case of proximal. The selection of one strategy of provisional stenting can be informed by IBUS. For example, when we have MLA insert over 3.5 and low pearl burden, we can really move to a provisional. But if we find the opposite, which is a MLA less than 3.5 and plaque burden over 50, then IBUS is telling us that maybe a 2-stent technique is more recommendable. What have been the publications, the more important publications? The first was the Korean experience. They matched 145 patients with and without IBUS for DES implantation in left main, and they found a late benefit in mortality. But the study was not large, but this late appearance of difference in mortality was not definitely pure mechanistically. In Spain, we conducted a pool of several registries, and finally we were able to match 505 patients with and 505 patients without IBUS guidance of left main PCI. And we could see a significant decrease in cardiac death MI and TLR along the 3 years follow-up. And very important from the point of view of mechanistic explanation of this benefit is the definitely improbable thrombosis difference between IBUS and IBUS. You can see in the right-hand side of the slide, which is really remarkable. In the left main distal subgroup, the difference is even larger in MACE. And for the subgroup of patients with 2 stents in the distal left main is really dramatic, the difference between those with IBUS and without IBUS in the outcome. IBUS emerged as a predictor of outcome in this study for the overall population, but more clearly for the distal left main lesions. IBUS makes a difference in sizing and post-dilatation. In our research, we could appreciate that the use of IBUS was associated with larger stent sizing and also more frequent and aggressive post-dilatation. All of this is exactly moving in the direction of getting larger minimum stent areas when using IBUS compared to just angiography. And all the registries published so far show consistently a benefit of IBUS guidance in terms of MACE, but also in mortality and cardiac mortality. It's clear that these are registries, not randomized trials, but it's important. The EXO trial has a subgroup analysis for IBUS, and in this analysis, when they classify the patients in 3 tertiles according to the minimum stent area, they provide this chart when we can see that there is a significant reduction, significantly less events after 3 years in the group with larger minimum stent area compared to the lower minimum stent area. This death MI stroke, is all-cause death, is MI, and is thrombosis of the stents. The other important trial comparing PCI and CABG is Nobel, and Nobel has also a sub-study for IBUS. They published these findings. The IBUS group tended to have lower MACE in 5 years, but TLR was definitely significantly less frequent in the group with IVUS. Following the same analysis like in Excel, comparing the upper and lower tertile for minimal staining area, the trend for decreasing 5-year MACE was stronger, and there was a dramatic decrease in TLR, 0% in the larger MSA group compared to 12% in the lower MSA group. A registry published from the British group, national registry, large numbers, over 11,000 cases with 6,000 no imaging, 5,000 imaging, and significant difference in mortality in favor of IVUS imaging. Very importantly, because this was not a benefit that was decreased with operator volume, but the opposite. The operator volume increases the IVUS-related prognostic advantage. And the multivariate analysis showing that IVUS was independent predictor for outcomes. As I say, these are registries, and we need a trial. In the optimal trials enrolling patients now, these are trial in 3 European countries, randomizing 800 patients to IVUS and no IVUS during PCI of lead main, and we will have important and definite information in this regard. We have then a class recommendation for IVUS to guide lead main PCI, and this other consensus document that was published in 2018 we recommended really the use of IVUS to assess lead main stenosis, but also the consensus opinion was to use IVUS to guide lead main PCI. This is a publication from our group, from our research group here in Santander in Spain this year, and we tested the outcomes in a group of patients with protocolized IVUS guidance of lead main PCI compared to the just previous IVUS guidance without predefined optimization criteria and with a geographic group. And it's very clear that there is an increase in the primary endpoint, and lead main TLR is the lowest when you follow a strict protocol of IVUS guidance with predefined optimization criteria. And what optimization criteria does, this is very well described in the manuscript, but you can see here some details for the optimization of ostial and mid shaft. When you see what are the criteria for the expansion, which is based on the proportion, more than 90% of the expansion with respect to the distal reference lumen. We take consideration of the shape of the main, and for the funnel shape, this proportion is the threshold is down to 80%, and also pay attention to position, stent ages, etc. For distal in lead main with provisional stenting, and for distal with two-stent technique, also criteria based on the percentage of expansion with respect to the reference lumen, taking again consideration for the shape of the lead main. Some tapered lead mains have a decrease in the size, and then the threshold for expansion is moving from 90 to 80%. And again, pay attention to position, no proximal stent deformation, and stent ages with the plaque burden less than 40% and no dissection hematoma. This criteria applied systematically is associated with a benefit in terms of prognosis. What about a CT? Of course, you can do a CT for lead main lesions, but they have some concerns and limitations. Particularly, lead main is frequently a large vessel, and poor visualization is possible, particularly in ostial shaft lesions. Also in some distal lesions when the lead main is very short and very wide. In distal disease, the physical characteristics of the catheter make more difficult and troublesome to negotiate the access to the syncophus, particularly with very angulated takeoff. There is no validated threshold in MLA for assessment for deferral of lead main lesions as we have for IVUS. There is a correspondence of 6, is not exactly no CT the same than 6. No plaque burden data, and this means a less accurate disease assessment, and the stent landing size could not be properly selected if we don't see the plaque burden. And no visible total vessel cross section. This limit is establish a limit to the sizing approaches that should be based on the lumen. Finally, status support and intravascular guidance for lead main PCI are based on IVUS, and there is no evidence with CT so far. We will have for sure, but not now. My conclusions are that IVUS imaging for lead main disease is definitely helpful. Definitely helpful to assess lead main lesion in ambiguous geographies, evaluate disease extension to LAT insert, characterization of the plaque, planning the PCI strategy, guiding the plaque preparation, sizing the stent, sizing the pot, and optimizing the results. All this guidance provides a prognostic benefit with respect to the use of angiography alone in hard events, particularly when using protocols with predefined optimization criteria. Then my final advice is get advantage from IVUS when dealing with left main disease. Thank you.
Dear Chairman, thanks for this invitation to present at EBC 2020. The title of my presentation is Can OCT Superior Resolution Offer More Than IVUS in Guiding Left Main PCI? Insight from Lemon. As you know, IVUS guidance improves the prognosis in left main PCIs. These several studies showed that in the past, and they are summarized on this slide presenting a meta-analysis. And as you can see, the use of IVUS can decrease the incidence of all-cause death or cardiac death following the procedure, and that's why IVUS is now recommended in the international guidelines to guide left main PCI. However, we also know that OCT is feasible and more accurate than IVUS in distal left main. The Cleveland group previously showed that left main analysis by OCT was feasible and that the left main dimension could be assessed either by IVUS and OCT with a good correlation, although the lumen areas measured by OCT were smaller than the ones measured by IVUS. However, OCT has also a better sensitivity for detecting abnormalities such as dissection, as you can see here, or stent malapposition. This slide presents you a head-to-head comparison of IVUS and OCT following a stent implantation in the left main, and you can see that OCT can detect these malappositions that were not identified by IVUS. And that's what the author reported on their cohort of 47 patients with a much better detection of this protrusion, malapposition, thrombus, or dissection. So that could make sense to hypothesize that OCT would be a valuable option to guide stable or unstable non-ostial left main lesions PCI. And that's the hypothesis we tested in the Lemon trial, which was a prospective multi-center trial performed in France, in which we decide to guide the left main PCI with a standardized protocol using 3 runs of OCT. The first one was performed at baseline to assess the metrics, the plaque compositions, and to decide the PCI strategy. It was followed by the stent implantation and the pot dilation based on the dimension we measured with OCT. Then the side branch was rewired. A second OCT run was performed to assess the position of the wire. And then in case of adequate position, side branch position, the procedure was completed with a side branch dilation and report or a final kissing balloon inflation and early pitfalls correction. A third run was then performed to assess malappositions, to measure the expansions, and to identify potential dissection. And in case of angio and OCT results were good, the procedure was terminated, or further optimization was decided and controlled by OCT. The primary endpoint of this study was the procedural success that was defined as a tear-free flow in all vessels, a residual stenosis less than 50%, and adequate stent expansions according to the Lemon OCT criteria. The secondary endpoints included the appropriate wire position in an adequate stent cell, the 1-year incidence of major adverse cardiovascular events, and also contrast agent volume and radiation dose. This slide summarizes the baseline characteristics of the 70 patients that were finally included in the analysis. You see that most of these patients were male, and most of them suffered from a chronic coronary syndrome. The left main lesion was mostly a bifurcated lesion. The one-stent technique was largely used in the vast majority of our patients, and pot side report was used in 2/3 of these patients, whereas pod kissing strategy was used in 36% of the patients. In case the two-stent technique was used, T-stent and TAP techniques were used in our patients. This slide summarizes the pre and post PCI analysis, and you could see that actually we observed a very good expansion in both segments of the stent with a correct minimal stent area. However, we also observed high incidence of significant malappositions despite all our efforts to correct them, and high incidence of edge dissection in the distal part of the stent. So the primary endpoint was finally observed in 86% of our patients, and in case the primary endpoint was not achieved, it was because of an inadequate stent expansion that was quite challenging to obtain in the very proximal part of our stent in the left main. And the 1-year incidence of MACE was very low, and we observed only one case of intrastent restenosis at 1 year, which was very, very promising for the future. So the question is, based on this data, what can we expect from OCT that is not provided by IVUS? And that was the title of my presentation. I would say the first point is a more accurate identification of early PCI pitfalls. And I will take the example of the malaposition. I previously showed you that malaposition is much more, could be identified in a much better fashion with OCT. And I would like to present you this data reporting the evolution of the malaposition parameters between the second run, just after the pod, and the final run in the lemon of the protocol. So you'd see that the major malaposition incidence based on the PCI criteria was very high just after post-pod, especially in the proximal stent segment, probably because of an inappropriate use of a pod. And more than one patient out of two suffered from a major malaposition, and this incidence was decreased to 19% in the proximal segment and from 30 to 11% in the distal stent segment. And although we kept on observing this notable incidence of malaposition, we also observed that all the parameters for malapositions, including radial extension, malaposition length, and the maximal distance between struts and the vessel wall, were decreased between run 2 and run 3 after the operators identified these pitfalls and corrected them. One of the questions rising about lemon was, is there any difference between the patient treated with final kissing balloon inflation or port side report? And I present you unpublished data about the impact of both strategies on the proximal segment, the left main segment of the stent. And you see that we were not able to observe any significant difference between the two techniques for the minimal stent area, the expansion percentage, or the percentage of significant malapositions or edge dissection. However, we are still working on this data, and we have not as yet assessed the impact on eccentricity between the two techniques, and especially for the final kissing. But I would like to highlight also that the proximal reference segment displayed a significant eccentricity in both groups. The eccentricity was defined as the ratio between the maximal luminal diameter and the minimal diameter in the reference segment, and you see that this ratio is over 1 in most of the patients. Second point that we can expect is probably and certainly actually an accurate wire position assessment in side branch that could not be achieved with IVUS. I know that this point will be extensively presented by the next speaker, so I will be brief, but these are examples of adequate wire position that you can observe using the 3D online reconstruction of the OCT system from Abbott. And these are examples of inappropriate wire position. And in the patients included in Lemon, this wire position was analyzed in 97% of the patient by the core lab, and the core lab concluded to an adequate wire position in 81% of the cases. However, the wire position was also reported by the operators in 60 cases, and in these 60 cases, I have to admit that the correlation between the core lab and the operators was pretty limited, as shown by the inter-observer kappa coefficient. So suggesting that there's still a lot to do to improve the education of the operators and to have a better use of these tools. So in conclusion, ladies and gentlemen, the Lemon trial was the first trial to prospectively assess the feasibility of OCT guidance in non-ostial left main PCI, and these initial data showed a good feasibility and safety of the technique. OCT's superior spatial resolution and the use of online post-imaging processing solutions compared to IVUS might help the physician to achieve better procedural success, results and a better success, of course. But this hypothesis has to be tested by comparing the two intracoronary imaging modalities in future trial. Whether it will be non-inferiority or superiority trials remains to be discussed. And I thank you for your attention.
Thank you, Chairperson. It is my great honor to attend the EBC 2020 virtual. I'm Burzotta from Japan. My topic is 3D OCT guided left main bifurcation PCI. Recent innovation of OCT is 3D reconstruction, which provides a clear visualization of the guide or recrossing point for the side branch dilation. So we conducted Japanese 3D OCT bifurcation registry to invest the effect of the detection of the guide or recrossing point to the side branch using a 2D or 3D OCT on the bifurcation stenting. In this study, we divided the two types according to the link connection at the current site. There is no link connection, link-free type. There is a link connection at the current site, link connecting type. These are the representative case. The link-free type distal wiring can be achieved wide opening. However, a link connecting type, even after distal wiring, link connection still remained at the side branch ostium. We defined the distal wiring in link-free type as LFD type. We compared LFD and non-LFD type in terms of the incomplete strata apposition after kissing balloon inflation. Here you can see in the side branch ostium, LFD type has lower incidence of incomplete strata apposition compared to the non-LFD type. We conducted the multivariable analysis for detect the predictor of incomplete strata apposition. Here you can see link connecting type and distal recrossing are strong predictor of the incomplete strata apposition. This slide shows the success rate of the optimal guideway recrossing. In the left panel, first attempt, that means the angio-guided wiring, succeed in the optimal wiring in only 66%. Accumulating the attemptation, OCT guidance elevated the success rate up to 87%. In the right panel, that is the comparison between the left main versus non-left main bifurcation. In the left main bifurcation, first attempt succeeded in optimal wiring in only 56%. In this study, we conducted a sub-study comparing the 2D OCT guidance versus 3D OCT guidance. About half of the cases, we use the 3D OCT software on site. In terms of optimal recrossing, in the free current type, complete success was achieved in the 3D OCT guidance versus 85% in the 2D OCT guidance. In the whole case, distal recrossing can be achieved in 91% in the 3D OCT guide and 76% in the 2D guide. And the average recrossing time 1.6 versus 1.1 times, and more than 2 recrossing time was required in 3D OCT guide, about half of the case, and the operation time was longer by 15 minutes in the 3D OCT guide. This is the comparison in incomplete strata position. In all cases, there is a favorable trend in the 3D OCT guidance to reduce incomplete center position in the side branch osseous side. However, in the left main bifurcation cases, this trend has been changed to the statistically significant. So 3D OCT guidance is more favorable in left main bifurcation. These are the representative cases of failure of optimal guidewire recrossing under the 2D OCT guidance. The operator cannot identify the actual guidewire recrossing point. In the upper case, here you can see guidewire recrossing in the small cell in the side branch ostium and the final kissing balloon inflation. Here you can see the most of the gel strut remained at the side branch ostium. In the lower case, here you can see guidewire recrossing is a proximal cell. The operator performs the kissing balloon inflation. However, gel strut protrude into the member cell. These are the representative cases of 3D OCT guidance in the link-free type. In the upper case, we favored the optimal distal wiring in the first attempt, so we changed the guide wire from the proximal to the distal cell, and final kissing balloon inflation was performed. Here you can see optimal wide opening for the trifurcation region can be achieved. In the lower case, we also failed the distal wiring in the first attempt. So we performed the part. Some fast widening of the distal cell can be achieved. So we succeeded in the distal wiring, and final kissing balloon inflation promotes a wide opening for the side branch. These are the 3D OCT guidance cases in link connecting type. In the upper case, here you can see link connection at the side branch ostium. We recross the guide wire in the distal larger cell. In the second attempt, we performed the final kissing balloon inflation. Unfortunately, the wide opening can be achieved. However, the ring connection still remains at the limb of the side branch ostium. The lower case, guide wire recrossing into the distal smaller cell. Here you can see we performed the final kissing balloon inflation at high atmosphere. However, link connections still remain at the center of the side branch ostium. Another option is the balloon push technique. This is the 1-0 or LM bifurcation region, crossover stenting performed, guide wire recrossing in the proximal cell. And under the anchoring of the LED balloon, the 2.5 mm short balloon was pushed from the left main to the SX, and the final kissing balloon performed. Here you can see a good expansion was achieved in the side branch ostium, and no gel strut in the side branch ostium. This is the current concept of the side branch treatment according to the side branch gelling strut configuration. We added a new concept, no or less gelling type, in addition to the two previously reporting type. When we encounter the link-free type, 3D OCT guidance is strongly recommended for the optimal side branch treatment. When we encounter link connecting type, 3D OCT guided distal guide wiring does not always lead to the optimal result. More aggressive part may induce the extension of a far distal cell into the side branch ostium, which is more appropriate for the guide wire recrossing. Push balloon method is another option. When the side branch is small, we can leave it. No or less gelling type, we can leave it with confidence except for severe side branch compromise. We conducted another study comparing the pot versus non-pot. In terms of guide wire recrossing, a pot group has succeeded in the distal wiring the first attemptation in 65% versus 72% in the non-pot group. Proximal cell 21% versus 14%. In terms of gel strut configuration pattern, link-free type 60% versus 49%. However, there are no significant difference between the two groups. Therefore, in the study, pot was not effective to enhance optimal guide wire recrossing. So we investigate the manner of pot in leading 4 hospitals in this study. Surprisingly, a manner of pot was different among 4 hospitals. Please note the pink color indicates the hospital C. In terms of stent expansion ratio, plateau level of the proximal member cell around 1.2 which is much lower than other hospitals, especially in the PMV +1 level. That means 1 millimeter apart from the carina. This value is much lower. As a result, incomplete stent apposition, hospital C has more frequent incomplete apposition in the POT group compared to the non-POT group. Indeed, this hospital has more proximal wiring compared to the other hospital. Therefore, the POT balloon should be located with the distal marker at the carina, which promotes distal J-ring strut wide opening, and optimal distal wiring is promoted and malapposition decreased. However, suboptimal POT indicates the smaller balloon located more proximal side promote the proximal gel cell widening like this, which promotes the proximal wiring. As a result, malapposition is increased. Ladies and gentlemen, this is my conclusion slide. 3D OCT guidance promote optimal guideway recrossing and less incomplete stent apposition after kissing balloon inflation. Monitoring the stent configuration during additional procedure after members stenting with 3D OCT is effective to reduce stent failure. Thank you for your attention.
Great. Thank you, Yoshi. I mean, it's incredible data that you gain from the resolution of the OCT. And I guess now we're doubly confused. So we put the POT balloon too proximal, then we risk clustering stents across the ostium. We put it too distal, we risk shifting the carina. We, in theory, create a kind of candy wrappering effect at the ostium and bring the very proximal portion of the stent inward. I mean, clearly we do need to take great care in these important techniques. I maybe turn to Jose, just in terms of the first presentation that you gave. I mean, clearly you've shown an advantage in terms of using a dedicated algorithm for the use of IVUS. How do you then balance what we've just seen in terms of the resolution of OCT and being able to guide wire placements and positioning to such high resolution, Chima?
Can you hear me? Because I cannot see my imaging. I think it's here. Okay. It's true that OCT provides higher resolution, but it's true as well that minor findings that are so minimal that cannot be appreciated by IVUS could be not relevant. For example, malapposition. The resolution of IVUS allows to detect malappositions up to 0.5 millimeter. Only malappositions that are smaller than 0.5 millimeter, that are in the range of 300, 200 microns, could be not detected by IVUS, but could be detected by OCT. These in fact are the malappositions that are tolerated because have no effect on prognosis and outcomes. No, it's the same for dissections. A dissection that is not visible by IVUS, and we have now HD IVUS with 60 megahertz is the one we are using now more commonly for the optimal trial. Really, I don't think that any the infrasonic finding is going to make a difference in outcomes. Then OCT provides very nice imaging. 3D OCT is very fancy, very beautiful, but I don't see it's really meaningful in terms of clinical outcomes.
Okay.
Nicolas, I had a question for Nicolas about the Lemon study. There were only around 17% of these patients treated with 2 stent techniques. I'm wondering whether there is some kind of selection of these cases. Of course, they were selected because it's this initial feasibility study. Do you think that OCT can be applicable to the normal population of the left main that we treat in our cath labs that are mainly, in general, old patients, diffuse disease, calcification? Diffuse disease is, of course, another problem for OCT apart from ostial location. Nicola, you're on mute.
Yes, no. So yes, thanks. That's a very good point. And I think that OCT can be used in our daily patients. And actually, that's already a tool that we use in our daily practice in our cath lab and in our French cath lab for treating the patients with the real life patients. I mean, of course, I assume that there are more like a vast majority of one-stent patients or one-stent treated patients in our cohort, because that's also a reflect of what we have in our cath lab. I think I would like to know about Thierry's opinion, but in France, most of the patients are treated with a one-stent technique. And I read, so of course I've attended to Chemla's presentation, and I'm not sure that we can't use this patient we can use OCT in large vessels, in a diffuse disease, in calcified lesions, because that's something that we can do regularly today. And for example, if you have some tips and tricks, if you know all the tips and tricks to get a good OCT image for a large vessel, this is completely something that you can do. I mean, for myself, the only limit is the ostial lesions. These are the ostial lesions. That's something that is not major limitation, but that's not something that we can, of course, favor in all the operators. I mean, there are some ways to overcome this limitation, but right now I would say that it's more orthodox to say that OCT should be limited to a mid and distal left main lesion. But in all these cases, including two stents technique, calcified lesions, rota, shockwave, whatever you want, OCT is always very useful tool and valuable option.
Diffuse disease, the problem. Sorry.
Yeah, I'm sorry. Yeah, after you. Go ahead.
No, I was just going to say that maybe diffuse disease can be also a limitation where you're not really able to see the real size of the left main. If you have very diffuse disease and lipids, and you are not able to see the real size of the left main at any point, which is unusual because, as you mentioned, in general, there will be some frames where you can really estimate the size. So I agree with that.
Yeah.
In the left main OCT study, the guide extension catheter is very effective to show the clearly. And telescope guide extension catheter, the tip of the guide extension catheter, tip of catheter and the guide extension catheter can penetrate the infrared light, so we can see the clearly the left main lumen, ostial lumen. So we perform such a case. We insert the guide extension catheter, and to understand how large the left main bifurcation, left main ostial lesion.
Thank you. Janice, please.
A very practical question for Yoshi and Nicholas. Beautiful presentations, outstanding data. Very quickly for the audience and the operators that they listen to us. When you have suboptimal positioning of the wire to the side branch, do you appreciate this with real-time OCT or with offline after the pullback? And if it's real-time, I guess it's conceivable that then real-time you can correct the wire position. If it's offline, how can you secure that by repositioning you are the correct cell, because there's no imaging to follow up?
And in my presentation, offline software we use, it takes 5 minutes. However, nowadays, in the present day, we use online software in the Abbott machine and the Thermo machine. It can provide clear images within 1 minute. So we can judge as an appropriate position or an inappropriate position, and link connection, gel strut pattern. So we choose the strategy. So link free type, we should perform the 3D OCT guide wiring. We can elevate the optimal wiring, the optimal subsequent side branch dilation, more than 90% of the case. So beautifully, the side branch open up.
So final case inflation, the clinical result of final case inflation elevate more.
And Nicholas, you did the same thing. You did the real time.
Yes. Yes, we can. That's, I think, all the beauty of this RCT software, that you can do it online, real time, and then use the information you get from the run to correct your procedures and to adapt your strategy. But I would, as I mentioned in my presentation, we see that there is a gap between the core lab, the expert knowledge and the less experienced operators. So that's definitely something, as I mentioned, a lot of education to provide to all the operators.
Or we can have you available 24/7. We'll be sending you images and then you
Oh, that I will be really pleased. I can give you my cell phone number for WhatsApp. That's already something that we do in France.
Don't say that.
Nicolas, before you overcommit yourself, why don't we move on to Niels, who may be able to share the load, because I hope he'll be showing us from the experience of the ongoing recruitment to October, also what can be achieved real time in the study scenario, but then some insights also from Noble Ivers. So Niels, maybe we move on to the recording.
Do fine, thanks. Thank you very much. It's a huge pleasure to be able to present the Noble Ivers sub-study here at EBC 2020. I would like to thank in particular Andy Ledwiniak, did a huge job on this study. You may be familiar with the primary endpoint of the Noble trial. After 5 years, PCI did not show non-inferiority, and CABG was actually superior to PCI. If we look at the secondary endpoints, all-cause mortality was very similar after PCI and CABG. However, non-procedural myocardial infarction was higher event rates after PCI. And in repeat revascularization, we also saw higher event rates after PCI. If we look at the subcategorization of the repeat revascularization, target lesion revascularization, meaning any target lesion revascularization, was 12 versus 8%. De novo revascularization was 7 versus 3%. And target left main revascularization was 10 versus 7%. So this indicates that the contribution from de novo revasc and other target lesion revascularization actually had quite an impact on the difference in repeat revascularization here in this trial. Now, in Noble, the use of IVUS was strongly recommended. However, IVUS criteria were not detailed in the protocol. So this is the sub-study that came out earlier this year, published in Eurointervention. Very happy for that. And 77% of the patients were in the PCI arm were assessed with IVUS. If we look at the two groups, no IVUS versus IVUS, there was some differences. Of course, it was not randomized for that, so we should expect some differences. And it could appear that the non-IVUS assessed group had a slightly higher risk. You can see hypertension was slightly higher, age was slightly higher by 3 years, Euro score could be slightly higher, and the use of newer generation drug-eluting stents was actually lower at 82% versus 93% in the IVUS group. So if we look here at the outcome in patients that were assessed with IVUS post-PCI versus no IVUS, we can see that in terms of MACE and non-procedural myocardial infarction, there could be an indication of a positive effect of IVUS, but none of them reached statistical significance. If we look at repeat revascularization, there was also appeared to be a difference, but again with a p-value of 0.11. However, if we look at the specific left main TLR, we can see that the difference reached statistical significance. So with a hazard ratio of 0.44, there was a significant reduction in target lesion revascularization of the left main if IVUS was performed. So we looked to see if there was an effect of also using pre-IVUS. So in the cases where pre-IVUS was assessed, that is either both IVUS and only pre, we had just 29 cases where only pre-IVUS was assessed, and then we had only post-IVUS. You can see all the IVUS groups were completely superimposed in terms of left main TLR here after 5 years, whereas if no IVUS was performed, it had almost double the event rate here. If we look at minimal stent area in the left main, how did that impact MACE after 5 years? Patients were divided in 3 groups of the 3 tertiles, the upper from 13 square millimeters and above, an intermediate of 10.9 to 13.3 square millimeters, and a lower tertile of 4.4 square millimeters to 10.8 square millimeters. So if we see the green line here indicates the upper tertile, and it could appear as it had an effect on overall MACE, but as you can see, there was no significant difference between the 3 tertiles here after 5 years. If you look at any repeat revascularization, there is now an effect for the patient who had a minimal stent area above 13.4 square millimeters. The event rate was low at 5% for repeat revascularization versus 14 and 18%. These are Kaplan-Meier estimates. So if we look at the specific left main TLR, if patients was in the lower tertile, they had a quite high event rate at 12% revasc versus 5% in intermediate, and actually none of the patients in the upper tertile required repeat revascularization of the left main after 5 years. So if you look at the CAN criteria, so published in 2011, have had profound impact on left main treatment, and for many good reasons. If we look at patients that fail to achieve the minimal stent area in any of these segments, so 8 square millimeters in the left main, 7 in the bifurcation segment, 6 square millimeters in the LED ostium, and 5 square millimeters in the circ ostium, well, we can see that failure to achieve the minimal stent area versus no failure, none of them for the individual endpoints and the composite endpoints reached statistical significance. However, we only had 221 patients in that analysis. And if you look at the percentages, it's numerical differences. It could indicate that there might be an effect with 37% versus 20%, 16% versus 5%, 16% versus 4%, and 16% versus 12%. So in conclusion, IVUS assessment was associated with reduced TLR of the left main stent. Better stent expansion was associated with superior clinical outcome. The CAN criteria may need to be revisited as larger left main minimal stent area provides benefits, and calcifications in the left main stent was associated with lower stent expansion. So this leads us to the final statement that intravascular imaging should be considered for routine use in left main PCI. Promise to provide an update here for EBC on the October trial. So some of you will be familiar with the design. It's a 1,200 patient randomized trial comparing a strict OCT guiding protocol versus standard practice, where you can use iOS as an optional tool, mostly as a bailout tool. We enroll both left main bifurcations and non-left main bifurcations with larger side branches above 2.5, and it has to be true bifurcation lesions. The primary endpoint is 2-year MACE for superiority, and we follow the patients for 10 years. So we have published the design of the study, including the study instructions that can be downloaded as a supplement to the main publication. It's detailed for provisional stenting and for the 4 main 2-stent techniques, QLOT, DK, cross, T, and TAP, how to do perform it with OCT guiding. So we have 34 active centers at this time, and a few, these are all the green dots, and a few more coming on board shortly as the yellow dots. Looking forward to that. We have unfortunately a few red dots. That is due to our legal department has some objections to a paragraph that causes continuous problems. So we're very sorry for that. But we're very happy for the group we have, and we will probably end with 44 centers in active enrollment shortly. If you look at an enrollment graph, we have now 866 patients included, and of course it's very difficult to forecast enrollment during this pandemic, but we hope to enroll the last patient in September 2021. So thank you very much, and hope you will have a continuous good EBC 2020. Bye-bye.
Thanks, Niels. So we're going to move swiftly on to Yannis's presentation just for the purpose of time, but then hopefully can discuss that data towards the end.
Cath Lab Director at the University of Nebraska Medical Center. I'm so thrilled to be here today in the virtual EBC. It's a whole new experience. My talk is on crystal ball gazing, the role of simulations in enhancing left main standing outcomes. These are my disclosures. And I'm going to start with the architecture of our computational standing platform. You see, we start with incorporation of intracoronary imaging and angiography, where we 3D reconstruct the wall and the lumen. Then we mesh the reconstructed vessel. We assign plaque material properties. We perform computational stent and balloon expansion. And then finally, we have the endpoints of the outcomes of the platform, which is morphometry of the stent, as well biomechanical indices. This is an example of a patient-specific left main 3D reconstructed bifurcation with fusion of angiography and OCT. You see here the reconstructed bifurcation. Then in the insert, you see a cross-section of this bifurcation showing the normal wall as well as the plaque. The beauty here in this platform is that we assign patient-specific material properties coming from OCT. You can appreciate here the different zones with different colors along the reconstructed lumen, and each zone gets a material property by OCT, all the way from very soft lipid-rich material to very stiff calcific material, as well as the spectrum to cover them in between, fibrolipid, fibrocalcific, and different variations. We incorporate then in our platform realistic stent designs and balloon designs. Here are 2 examples of 2 stents in the market in crimped and expanded state. That's an example of a patient-specific bifurcation with a tap technique, main vessel standing, side branch standing with slight protrusion to the lumen, and then finally kissing balloon inflation with good result. Again, this is all patient-specific. We then validated blindly, I need to underscore the word blindly here, our computational standing platform against reality. You see here angiography as computational simulations, and as you can see, we achieved very high agreement quantitatively between the simulated stents and reality, shown here as well as we have direct comparison of the simulated stents on the left with red, and then the OCT reconstructed stents in the middle with black, yielding very high agreement, very small biases, close to 0 millimeters, between the simulated stents and reality, speaking to the robustness of our technique to reproduce reality. These are overall results. Again, average MLDs between reality and simulations, 0.07 millimeters, and same for MSDs as well, mean stent diameters close to 0. That's an example showing illustratively the reality and simulation. On the top, we see the pre-stent cross-section at the bifurcation with different material properties. And then you see on the right, top right, the post-stent picture OCT with the stent expanded there. And then we replicated the same thing computation as shown on the bottom left, the reconstructed lumen cross-section with the assignment of material properties. This particular cross-section has lots of calcium shown here. And then on the right, the post-stent computational stent picture. And you can appreciate that areas and mid-lumen diameters before stent and after stent were pretty comparable between the reality, OCT, and simulations. Now, the question is, what's the applications? So what of this computational stenting platform? Here we summarize the applications. It can be used for clinical decision making when it comes to left main stenting. It can inform industry about left main stents. It can be used on virtual clinical trials and also help education and training. I'm going to walk through these applications quickly. How computational stent simulations can help us guide left main stenting techniques. We run now the FLOW-SR trial, a very interesting trial which is now underway. We use 120 patient-specific bifurcations. Each one is computationally simulated with 5 different techniques, 1 stent technique or 2 stents, culotte, decay, crash, T or tap. The endpoints here is biomechanics and stent morphometry. And then finally, we come up with an atlas of different bifurcation anatomies and stent simulations. And the whole idea is that we use advanced machine learning and statistics to come up with specific stenting techniques that fit to specific bifurcation anatomies and disease burden. Now, application of the computational simulations to guide left main stent designs. Here we have a study on Megatron. Megatron is a Synergy family stent, purpose-built for left main. The paper is now under review in CERT Cardiovascular Interventions. The company has 3 prototypes, the Megatron with 9 peaks, 10 peaks, or 12 peaks. The 12 peaks is the about to get FDA approval version. And what we did in this computational study is that we got 5 patient-specific bifurcation geometries. We assigned 4 different stent, we tested 4 different stent designs. We assigned 5 different plaque types with 3 different stent expansion diameters. And we used as comparison metrics different important stent performance metrics like stent expansion, vessel scaffolding, stent artery ratio, vessel prolapse, and radial strength. And as shown here, first of all, when it comes to vessel scaffolding, shown here on the top left, we found that in this computational patient-specific study, that Megatron 12 peak performs better when it comes to vessel scaffolding, significantly better compared to the 10 or 9 peak design or Synergy. And that difference, that superiority was observed across all the stent diameters. And more importantly, we compared our computational results with experimental results, benchtop experiments, and we found very, very high agreement supporting the idea that the computational platform we used here to test these Megatron stent platforms can very robustly replicate benchtop experiments. Vessel prolapse, the Megatron 12 peak version showed much improved, smaller vessel prolapse compared to the other 2 versions of Megatron plus Synergy. Radial strength, as shown on the top left corner, the Megatron 12 had superior, significantly better radial strength compared to Megatron 9 peaks or 10 peaks or Synergy, and that was observed across all the stent diameters. And again, as with vessel scaffolding, these computational results faithfully replicated the benchtop experiments. And finally, application of our computational simulation platform to guide virtual clinical trials. This is the concept of the study, the virtual trials design. We have different stent designs or techniques. We can use real patient data, not actual patients, but real patient data, let's say bifurcations, and using surrogate endpoints, which are highly predictive of clinical outcomes, let's say stent expansion or hemodynamics, we can filter those stent designs to the best 2 or 3, and then we can go in a very focused and targeted fashion into actual clinical trials with real patients using actual clinical outcomes to produce meaningful results. So essentially, this pipeline, this virtual clinical trial pathway, can inform the FDA, NIH, different industry and regulatory agencies about actual clinical trials in a way that they can produce scientifically impactful results in much faster and much cost-effective way. So in conclusion, the computational standing platform simulations is a feasible approach when it comes to left main. It's an accurate approach. It can help us optimize left main standing techniques, and it can help us to guide virtual clinical trials and at the end of the day, actual clinical trials. I would like to express my deep gratitude to the dream team in my lab, the group of expert biomedical engineers and MDs, and of course, a big thank to our funding sources, federal and NIH funding sources, as well as industry and philanthropy supporting our lab. So with that, I would like to conclude, and now it's open to discussion. Thank you so much for your attention, and God bless. See you next year, hopefully in a beautiful Greek island.
A Greek island indeed, Yanis. We can all hope. Amazing data. Beautiful to see, the progress that's being made in the clinic with Niels in terms of October, but then the unbelievable potential that simulation offers. I perhaps firstly turn to Gabor, who earlier in the symposium has had the chance to present the DK culotte benchtop data. I mean, in terms of simulation, Gabor, what Yanis shows us is dreamlike, isn't it? What's your take on it?
Yes, actually, the difficulty with bench modeling, that there are many things what we cannot model with a limited number of samples. How the stent rotates, where really one stent ends, or where is the side branch, and so on. So all these niche details, but it can have a very important relevance on the stent performance. And most of the bench tests, they are limited to 10, 20, 25 cases. But we already understand that it would be much nicer to have 1,000 cases to simulate, and then you can have all these niche scenarios immediately. Considering all these computer-based simulations, I assume it doesn't matter where you do a test on 500 or 1,000 or 1,500, and then you might have a much better understanding on all these technical aspects of devices, cases, and so on. The same for angulation of the side branch. When we do bench testing, we have a model with 90 degrees, 60, maybe 45 degrees. But if you can simulate the whole range in between, then you have a much global understanding on the whole story.
Yeah. Jens, you have a comment?
Well, yeah, it was really excellent presentations, and it raises a lot of questions as well. But first of all, I would like actually to congratulate Gabor on that fantastic paper they published in Euro Intervention, because they used simulation to underline the importance of the change they made in the DK cross technique. So actually they improved a known technique, and actually they underlined why it was important to do the double kiss, and they used simulation to do that. And then again, this is a tool to show us if we make changes, what those changes really imply, based on the actual situation where you have the technical scaffold to make the simulation on. I'm very fascinated by Yanis's talk, but there is also the risk when you use prediction and then conclude that a prediction is right and then use it for a randomized trial, then you are in high risk of having a circular argument. So the problem is that I guess there's known knowns, and then you can actually take those into account and put them into the model. There are unknown knowns. Those can be found and maybe mathematically simulated. But then there are the unknown unknowns, and those cannot be put into a predicting model for the single patient. It takes huge numbers of measurements. So I think it's a fascinating glaze into the into the magic ball for prediction, but I think there's a long way home for actually a very, very precise prediction of the outcome. So again, I think simulation has really a place where in the way that Gabor and his group showed us actually how to underline technical changes. So again, very, very fascinating, and you have to be congratulated to choose these presentations for this session, because it really underlines where we go in the future.
Yeah, if I can make a point here, first of all, benchtop simulations are indispensable. The same with the ex vivo simulations in the virtual heart lab. We have all been there, and we appreciate the importance and the beauty. The beauty with the computation simulations, which is another type of simulations, is that as Gabriel said, it's going to be more, faster, better. That's the three keywords here. But I totally agree with Jens. He always brings the notion of wisdom. Every technology, everything should be used wisely. So it's not the holy grail. It's a tool, a technological tool that uses new advances in technology to wisely be used and guide the clinical decision making and guide clinical trials, guide at the end of the day the art of medicine. There's an art here. It's biology. There's variability. There's no mathematics, and we always need to be to stick on this principle. Use technology to guide the art of medicine.
On my side, I am really impressed by what we are doing. I think that we are increasing more and more the OCT technology, and this is really the open window to the possibility to simulate well what happens inside the heart and the coronary arteries of our patients. So now I think that it is really time to collect big data and to, on parallel, work on understanding more what happens during the interventions with the details that we never had in mind up to 5 years ago. And I think that this is really the last part of the EBC, because this really opens the door to the future. And I think that good imaging, large number of patients assessed, and good technology like Ioannis shows, I think that is really a new way to make our interventions a little bit more predictable. And I think that we will benefit and learn a lot in the future.
Jessica, I think that's probably a great closing comment. I would think we're clearly, sticking to the EBC policy of running behind time. It's good to see that discussion continues from the very beginning to the very end of first session to the last session. I'm just very conscious of the fact that we are 20 or 30 minutes already over time. And as you can see on the panel, we're blessed to have many of the EBC board present. Ben, maybe you just put up a couple of final slides, but thank you to all the panelists for a fantastic session, really highlighting the importance of imaging in bringing better outcomes to our patients, we believe. And haven't we come a long way? Sadly, we are not standing in the lobby of a very nice hotel in Barcelona, albeit with war outside, but we are in our homes or wherever at work. But it's quite incredible that the EBC community has come together the way that it has to celebrate, really, despite COVID and this virtual world we've kind of made work. If you just make it a full presentation there, Ben, and move forwards to the next slide. So the reality is we're not going to be able to capture a picture of everyone who's attended. We have got some video grabs of the virtual platform from Zoom, and maybe Ben and I can come together to try and make a faculty photo for others. Ben, if you move forwards on the slides. But I'd just point you towards one session that perhaps hasn't been as well promoted as it could have been, and thank Remo Albiero for all the work that was done behind the scenes in choosing cases for the case-based session, which unfortunately we weren't able to show live. But this year we've actually had 3 dedicated themes: the best case, how imaging has saved my case, and a complication case. And there were 3 cases in each of those themes selected. And we've actually put that out to vote on Twitter. So there are now YouTube links in order to enable you to watch the 3 cases along with some discussion on the EBC platform. And we've left it open for a week for votes to be cast. And we've had over 30 or 40 votes, I think, in the best case session as yet. And we'll come together in a week's time and select the winning case overall, and then declare that on the EBC platform. And then beyond that, we've had some incredible metrics. So if you move forwards another slide there, Ben, yesterday we had over 700 users on the platform, and the global reach has extended far beyond what's previously been achieved through EBC. So the Philippines took the number 1. So Jens was concerned about perhaps the weather in the Philippines yesterday and what led to such high attendance, but it's truly wonderful to see attendance from the Philippines, from India, from United States in number 3. Thierry was concerned about the absence of France from the top 10, but he can be reassured that France came in at a healthy number 11, and perhaps just indicating the fact that people are having to turn their attention to COVID. And so with that, I would just say that, please stay safe. And it's been a fantastic 24, 48 hours of again, brainstorming and sharing. And I hand over to Jens and to the EBC board to conclude the meeting. Thanks to everyone.
Thank you very much, Tom. Thank you for leading this excellent session in the end, which really underlines why EBC is so important. And I would like to actually follow in your steps and thank all the participants from all over the world and all the panelists and all the presenters to have EBC where it is, even when we are not able to meet in person. I guess that all of us will miss the gala dinner so much. Meeting all the friends and having all the discussion. And I just now and then go and think how many studies is actually constipated during that gala dinner, how many friendship which actually broadened to collaboration worldwide has been made there. It's a bit of a shame that we can't do that at the moment, but this has actually worked better than we supposed. We have had a very good discussion over the internet, and I'm actually, on behalf of the EBC, so happy to see so many of you putting so much effort into it and be part of it. And again, I'm so excited over the last presentation and actually both Gabor and Yanis's talks and discussion that brings it forward that on top of all what we are doing, a new world of supercomputers and simulation and prediction and artificial intelligence opens up. This is an area that we really need to pursue in the future, as well as also all the other stuff we are doing with the clinical trials, with the bench testing, with the discussion, with the imaging, with everything. But again, thank you very much for supporting the EBC the way you're doing, and I'm really, really happy to see what we have accomplished also this year and by going virtual. And I guess maybe we should send a kind regard to Alex and Ben behind the lines, and I guess they haven't slept for 48 hours, I guess, and may need a glass of wine later tonight. But by saying that, I would actually hand the word further on to some of the other members of the board.
Yeah, I think first Thierry, then Yves.
No, I think it's time to conclude, Goran. So you can make the conclusion of this special EBC meeting.
Yves?
What I can say as Italian operator, after 20 years of bifurcation clubs, I am very proud from what we have done. And I was a bit skeptical about the virtual session, but I'm very proud also of all of you, what you have done, the presentation you did, and the project you are pushing on imaging, the fantastic project of Yanis. We began that a long time ago with the presentation of a case in Barcelona, unique case, done with a lot of difficulties in 3 months. And now you are able to rebuild a model of bifurcation in 30 minutes. So you plan to
EBC effort.
So this is, I think we did something that is copied now everywhere in the world. But we are still leading, I think. So what I hope is we will be leading again more for many years more. And of course, as all of you, I wish to see with you next year to the gala dinner of the next meeting.
Thank you very much, Yves. You always make this very emotional, so it's not easy to say a couple of final words. So dear colleagues, dear EBC friends, these 2 days we have done our very best to offer you useful educational platform and hopefully meet your expectation with this new digital learning experience. A big thank you to our respected faculty, to all presenters for dedicating time, and also big thank you to all of you, our attendees. We wish to thank also our industry partners for kindly supporting this first digital edition of the EBC meeting, and they contributed really the most valuable sponsored scientific program in very short period of time. Big thank you to Alexandra and Ben and the whole Mediate Events team, really for reliable technical support and excellent meeting organization. We will carefully evaluate the first EBC online meeting. Please tell us what you liked and what you did not like. We need your input to create better EBC meeting next year with more discussion, I promise, as every year. Now it's time to say goodbye. On behalf of the EBC board, we want to thank you for joining. We wish you to stay safe and well wherever you are. And it's my pleasure to officially close the first EBC online meeting. Thank you very much for great experience. Bye-bye.
Thank you.
Bye-bye. Bye-bye.
Thank
Bye,
you
thank
all.
you.
Bye, everybody.